Okay, I think we need to make a start. We have a long and very exciting day today. And I would like to, I'm Nona, I'm co-chair of MPN Voice. I'm lucky enough to be co-chair. And I'd like to extend a really warm welcome to all of you. It has been a joy to work with the Novartis team and to connect with all the patients here in the west of Ireland. And I hope you enjoy the day. Now, what is MPN Voice? MPN Voice was formed in 2003 by a small group of patients, haematologists and specialist nurse psychologists based at St Thomas's Hospital, London, and to provide a source of professionally backed, clear and accurate information and emotional support to everyone diagnosed with a myeloproliferative neoplasm and their families and friends. It's now based at Guy's Hospital. What I would say, it was an essential thing that we do provide accurate information. I'm a patient who was diagnosed in 1991, and I can assure you there wasn't much accurate information on the newly formed web at that time. This is a structure of our committee. You can see it's very well balanced. We have a strong clinical advisory committee. We also have different aspects that we do. There's an advocacy team, there's the forums team, a fundraising team. It is volunteers who make this all possible, and they, I always say, are our unsung heroes. A lot of you won't know them, but I can assure you they do a lot of work in the background, and for that we're very, very grateful. In the last year, we set up an online survey for setting our targets for this year. What was really interesting about this, to me, was how it goes right around the world. And having started as just a small charity at St Thomas's Hospital, you know, we're incredibly lucky now and consider ourselves to be a global community. You know, we spend a lot of time in asking for what patients want, and we do listen. So that's why it's really important we get the feedback. We support people in different ways. We do online information and support, our website. I don't know how many of you have seen our website or clocked into our website. Okay. Well, there's a lot that haven't, and that there's something that is, if you're able to access the internet, you would learn a lot from the website, because pretty much everything I'm talking about is on the website, and there are links to help you get support and information. So the website is being updated, and when we get new research information, that goes on the website as well. Vlogcasts. Every month I do a conversation with someone in the MPN community, and they're short, but they are hoping to provide a library of information that goes on our YouTube channel for people to get help and information from. We do webinars, which are streamed from London. With the next one we're doing is on the 27th of July, and that is focusing on PV. So any of you with PV who would like to watch online, please look on the website where there'll be a link to how you can sign up for it. The Health Unlocked, now that's a huge thing. Health Unlocked, I don't know if any of you are on Health Unlocked. Great, do you find it helpful? Brilliant, because that is a source of information. And again, our aims for MPN Voice were to provide accurate information at all times. What I will tell you is, in terms of safety, it is monitored, and anything that is considered to be not in the interest of MPN patients or incorrect, we do take down, because it just keeps it a safe place for people to share. Facebook. Facebook, for those of you on the internet, is an active Facebook group, as there is with Instagram, and also Twitter. Now, the other thing that's also important is the Young People's blog. We have a patient, Alice, who does a monthly blog dedicated to young people. And that, I say young, it's anybody diagnosed under 40 years old. So there's a lot going on for support for the patient cohort, and it's not just in the UK. As I say, from the map I showed earlier on, we're truly a global community. Buddy support. That's really important, actually. When you're first diagnosed, it can be quite overwhelming. And we run a buddy program where you could be matched up with somebody who has your specific MPN, who has been diagnosed for at least 2 years. We do vet every person applying to be a buddy, and as a safety measure, we always ask them to tell us who their haematologist is, so that we can, if there's a problem or if there's something we want to know, we have the authority to contact their haematology. That makes it safe for them to be buddies. We also do drug and disease booklets, and there are travel and insurance guides. The other thing that I know the clinicians find really helpful is the MPN 10 forms. And those, certainly in the clinic I attend, the moment I check into the clinic, I'm actually given an MPN 10 to fill in before I see the consultant. There's also a fighting fatigue guide, and also we have these, which are MPN alert cards. So if you've got an MPN, and if you're unfortunate enough to be in an accident and end up in A&E, I think it's quite useful to have in there with your drugs that you're on, so somebody treating you knows exactly what you're taking. Advocacy, really, really important this, in particular to represent when decisions are made about drug funding, representing patients to the pharmaceutical industry, ensuring patients are consulted as part of the clinical trial process for new drugs. We have a member of the Cancer 52, an alliance of over 100 organisations working to address inequality and improve outcomes for patients and rare diseases. The recent work that we've done is NICE, which is the British version of NCPE. We did an appraisal for Dratinib, a new drug for myelofibrosis. And we also helped with the appraisal for the NCPE, the Irish equivalent, for ruxolitinib for PV. The Scottish Medicines Consortium appraisal for Besremi, a new formulation of interferon for PV. And we also did a joint submission with Leukemia Care for NICE for approval of ruxolitinib for PV. International advocacy, again, it's really important that we link up with MPN groups around the world. We are a founding member of the MPN Advocates Network, and that's sharing best practice about patient support. And helping, also this is so important, helping patients in less developed countries establish their own groups. The Young Patient Network, this is really exciting. It's a new thing that we've just started doing. And it has emerged out of recognizing that there are a lot of people who are diagnosed at an early age, and it can bring a lot of questions, a lot of difficulties. An example would be, you're young and you're suffering from fatigue, and all your friends are going out and you just simply can't face it. And so there is now a space for people in the UK and around the world to join this group specifically for young people. The network has a steering committee made up of enthusiastic MPN patients who will oversee the network's running and future developments, and it is clinically overseen by haematologists and clinical nurse specialists, thus delivering best practice. They plan to have a mixture of online and in-person socials throughout the year, designed to break the isolation of being a young person with a disease typically diagnosed when you're over 60. They plan to host a series of themed virtual meetings on specifics for young people and MPNs to include treatment, symptoms, and mental health, which is really important, exercise, diet, travel, maternity, When you're diagnosed with an MPN and you want to become pregnant, that has its own issues, and there will be support. Employment and careers and transformation, with guest speakers sharing their experiences and insights and answering questions. So there's a link here to the MPN Voice Young Patients Network. If you know anybody or any of the clinicians know anyone under 40 who would like to join this group, I would encourage them to do so. Patient forums, well, here we are. And I can't thank Novartis enough. It's been a joy to work with you all, getting this Galway forum up and running, and to see so many of you here. But also to the doctors, Claire Andrews, Aisling Nee, Professor Claire Harrison, who's come from London, Professor Mary Frances McMullen from Belfast, and of course, the clinical nurse specialist here in Galway, Sarah Connolly. Thank you all. It means a lot to all of us in this room that you have given up your time to support MPN Voice. We do now do a mix of forums. We do some online forums and some face-to-face, which of course, when COVID struck, we had to limit it to just face-to-face. COVID was a nightmare for all of us, but the plus side of it was that actually we had to get our act together and communicate with the patient community. And I don't know about any of you, but I hadn't heard of Zoom before COVID, and now we're utterly reliant on Zoom, even with our management meetings, fundraising meetings, executive committee meetings. We can do them on Zoom. We can talk to doctors on Zoom. It is amazing. But I do know that there are a percentage of people who can't sort of hack this whole computer business, and we're not going to forget that proportion of patients who can't do that. But we look at the number of people that are attending all these forums, and I'm always surprised when I open a virtual forum and I ask how many people are logged in from around the world, and it's increasing all the time. I mean, I'm never surprised. We now get Australia, we get Canada, we get America, we get India, we get a lot of European things. So the message is going from these clinicians who give their time, free of time, they give us their time, to people around the world. Also, you will be able to see this forum on the YouTube channel, and I do encourage people to log on to YouTube if you want to find information on previous speakers at previous forums. It's a valuable resource. Research. Research, working with leading UK and international healthcare professionals and MPN researchers to ensure patients' interests are supported by new research initiatives. Without these research projects, we wouldn't be anywhere. Because, I look at the drugs that have come online since I was diagnosed, and it's increasing, and it's a bright future for the MPN community. There's a list here of the current research projects. And if you're interested, I would suggest that you check it out on the website. And also here in Ireland, my co-chair and I, John, are being advocates for the Project Climb study, which is into clotting, which is a very exciting thing to be involved. And Landmark 2 is currently underway globally, and we hopefully will have the results of that in 2033. We're also hoping for some results from the Mosaic study to come late into next year, which I know a lot of patients have been keen to support the epidemiology study, looking at where MPNs come from. So there is a lot of bright hope in the future, but of course we still have to find funding for a lot of these research projects. Mithridate. That is a study that is very active at the moment. MPN Voice have been supporting it for the last 2 years. And it's a multi-center, it's an international study comparing ruxolitinib with either hydroxycarbamide or interferon first-line therapy for high-risk polycythemia vera. Very interesting study, and you will hear about that as it progresses. Mosaic, I've just talked about, but there's a site here open in Ireland in Cork, and then we have sites opening all the time. The map of the sites open in red is there, and the other sites are coming online soon. That's been a long, and I have to thank somebody here, Mary Frances McMullen, who has been instrumental behind the Mosaic study and dedicated a lot of her time to this. It's a really important study. I'm sorry I only have 10 minutes, so I have to be really quick here. There's so much going on in MPN Voice, and it's such a passion of mine, I can't cover it all. Grants to support research and training. We really have a mission to encourage research for the benefit of MPN patients. Funding can be requested by healthcare professionals to support either the entirety or part of specific research projects. A maximum funding will be set at £50,000. So that's open to clinicians from here as well as in the UK and elsewhere. There is a process that has to be done to go, an application has to be formed, and it is reviewed by our clinical team and our chief funding finance officer, Tim, and either John and myself with Claire. We also have a new Fiona's Fund. Fiona was a patient that we knew very well and was a very staunch supporter of MPN Voice. She sadly died last year, but has left MPN Voice a legacy. And we decided to set that up for supporting the educational needs of clinical staff, prioritising nurses, pharmacists, psychologists, and allied healthcare professionals like dietitians or physiotherapists, anyone connected with the treatment of MPNs. Funding will be prioritised to projects that can be shown to have a direct benefit to an MPN patient. Examples might be not limited to undertaking a prescribing or examination course, support for an improvement project. Funding will be provided through funding calls, but applications can be made at any time. A maximum funding will be set at £1,500 and will be provided after a review of the application. Now, that applies to everybody in Ireland too. We're not left behind. So we're hoping that we will get some applications from Ireland. Fundraising, donations and grants. MPN Voice would not exist without fundraising, without donations and grants. Like today, we're very grateful for Novartis Ireland for supporting this event today and the nurses event last night. We need the funds to provide research projects. We need to develop the website. We need to have a provision of printed resources for the healthcare and community and patients, and support to the MPN community via Health Unlocked Facebook and Twitter. Just general support to the MPN patient community, but also to the healthcare communities. If you would like to know more or be involved, please contact fundraising@mpnvoice.org. Let's do it together. And I know there's somebody in the audience, Mayella, and this is really important because Mayella was the first person to fundraise from Ireland, and she did the most amazing concert in Dublin, and raised, I think this is over €3,000. And it was just so lovely that it was done on Blood Cancer Awareness Day, and everybody enjoyed it. It was fantastic. But you have a look at this map. We're getting events that are done across the world, not only here in Ireland, but Australia, the USA, Spain, the UK. And that's key to the world MPN community being able to fund the research projects. There's another project, actually, that I do want to mention that isn't on a slide, but as a response from the 2022 survey, we are actively looking at developing an MPN app, which I think will be a help to patients and also clinicians. We are also looking at doing QR codes for our brochures and leaflets. So watch this space. It's in the early stages yet, but it's also important to mention, an example of how we're meeting the needs of the community. Now we have our first speaker, We have Dr. Ashley Nee from Limerick. Yes. I have to think. Sorry, Ashley. And you're going to give us an ET and PV overview. Welcome.
Thank you so much. Now, can you just show me? Oh, yeah, it's pretty straightforward. Lovely. Okay, so I'd like to say thanks, first of all, to the organisers for asking me to speak here today. And thanks to all the patients and family members, some of whom I recognise, for attending today. I've been tasked with providing an overview of 2 diseases in 20 minutes, so it's going to be a bit of a whirlwind, but I'll do my best. Because it's the first talk of the day, I feel the need to just provide a little bit of background on MPNs in general. I know there's many people here who know a lot about their own disease and about MPNs in general, but there will be people who don't know much, so I'm going to have to explain at a basic level as well, so hopefully everybody will benefit. So MPNs stands for myeloproliferative neoplasms, and to understand what they are, we have to understand, first of all, the basics of blood cell production. So our bone marrow makes all of the blood cells in our bloodstream. And what we're particularly focused on here is the myeloid side on the left there. So our myeloid stem cells produce our red blood cells, our platelets, and a lot of our white blood cells, with the exception of our lymphocytes. So of particular importance to this talk today is the red cell and platelet production. So when we talk about MPNs, this refers to any overproduction of myeloid cells, but usually we're actually referring to one of 3 diseases: essential thrombocythemia, or ET, polycythemia vera, or PV, and myelofibrosis, or MF. Claire Andrews, my colleague, will be talking about myelofibrosis later, and I'll be talking about ET and PV in this talk. But I just wanted to acknowledge that there are other rarer but equally important MPNs that exist. So just to talk about the incidence, because this is something that patients want to know when they're diagnosed, how common is this? How rare is this? So these are considered rare diseases. Unfortunately, at the moment in Ireland, we don't have very good data on our numbers, either incidence or prevalence. It's something we are working on. So I've taken these numbers from a study that was published of epidemiology of MPNs in the European Union. It was published in 2014, so it probably underrepresents current data. But just to give us an idea, in that study, the estimated incidence of ET was about 4 to 17 cases per million people per year. So that would kind of equate to 20 to 85 new cases per year in Ireland, which, as I mentioned, I think is an underrepresentation of the truth. The median age at diagnosis is mid-60s to mid-70s. And then when we look at PV, in that particular study, it looked like there were slightly higher numbers of cases of PV, but similar, and also similar age, median age at diagnosis. So what causes MPNs? I'm not going to go into much on this. There's a talk on it later by Mary Frances McMullen, but it's one of the things that I wanted to mention because patients also, with any new diagnosis, want to know why has this happened to me? They want to know, is it something they've done or something they could have done differently? And really, for the most part, as far as we know at present, there's very little that can have been done to prevent these. Lifestyle factors don't seem to be of importance. Environmental factors, in most cases, are not of consequence, and it is not generally a hereditary condition. So it's usually down to what appears to be a spontaneous acquired genetic mutation, meaning not our genetics that we're born with, but at some point in our life, any of our cells can acquire genetic changes that predispose us to different diseases, and this is the case with MPNs. Now I'll try not to get too scientific, but I know there are people who want to understand on a slightly deeper level exactly what's going on. So within our cells, we produce proteins that communicate with each other and tell our cells to do different things. So this signaling pathway, the JAK-STAT signaling pathway, is a really important pathway that happens within many of our cells. We produce proteins, they interact, and they tell us to produce more cells. They tell those cells to mature, where they should migrate to, and when they should die. And as such, it is really important in regulating normal blood cell production in our marrow. So the majority of myeloproliferative neoplasms are driven by increased activity in that pathway, and over 95% of cases of MPNs are accounted for by acquired, as I mentioned, not from birth, but acquired mutations in 3 genes that are important in that pathway. The JAK2 mutation, which a lot of people will have heard of, the CALOR mutation or CALOR mutations and MPL mutations. All 3 of those genes code for proteins that are important in that JAK-STAT pathway, and the mutant version causes increased activity in that pathway and therefore overproduction of cells. So just to quickly run through, the most common JAK2 mutation is the JAK2 V617F mutation, but there are rarer JAK2 exon 12 mutations that we see in polycythemia vera in fewer than 5% of cases. Then there's the CALOR mutation. Some patients, the reason I've included that there are subtypes is specifically I've had patients come to me and say, well, which type of CALOR do I have? Because they've done their own reading and understand that there's more than one type of CALOR mutation. So there's 2 main subtypes, type 1 and type 2. At the moment, those subtypes don't dictate any difference in treatment, but I'm just mentioning that there are 2 different subtypes, and I'll speak a little bit about that later. And then the rarest of the mutations, the MPL mutation. So just to focus on JAK2 V617F for a moment, this is, as I mentioned, the most common mutation. It's found in greater than 95% of cases of polycythemia vera. As mentioned, there are a small subset of patients with PV that have a different type of JAK2 mutation, JAK2 exon 12 mutations. Then when we look at essential thrombocythemia, still the majority will be positive for this JAK2 V617F mutation, but that's still only 50 to 60%. Those who are negative for JAK2, 30% are positive for CALOR mutations, about 5% for MPL, and then there remains about 10% that we can't currently identify a driver mutation, and we refer to those patients as triple negative, meaning negative for all 3 known driver mutations for ET. So just to talk about the risks and complications, and I've put ET and PV together for this because they have similar risks and complications. So thrombosis is the main thing that we focus on. Thrombosis meaning clotting within the blood vessels. It's the main cause of complications of both ET and PV. The reported incidence ranges from about 12 to 39% for polycythemia vera and 11 to 25% for essential thrombocythemia. And importantly, arterial thrombosis account for the majority of these events. And when we talk about arterial thrombosis, what we really mean are potentially serious incidents like heart attacks, strokes, peripheral vascular disease, things like gangrenous toes or limbs. Then the remainder are venous, so that can be clots in the leg, which are DVT or deep vein thrombosis, clots in the lung, pulmonary embolus or PE, but also MPNs cause more unusual types of venous thrombosis. So it is the most common cause of the unusual splanchnic venous thromboses, which are clots within the circulation in the upper abdomen, often to or from the liver, and can result in liver damage. So then the other thing to mention is transformation, and this refers to a change in disease behaviour from either ET or PV to a more aggressive bone marrow condition, which may either be myelofibrosis or acute myeloid leukemia. I won't go into much detail on what I mean by myelofibrosis because that will be covered in more detail later, but it's just worth mentioning that this occurs in a minority of patients, usually spontaneously after a long period of chronic phase or the current disease that they have, their existing disease. But we do know from the past that we have previously increased the risk in a subset of patients with certain therapies that are no longer standardly used, such as radioactive phosphorus or busulfan. Just to mention the rates of transformation, because I think it's really important when I'm speaking to a new patient and they hear this could change in behaviour to something more serious, just to highlight how low those rates are. So for essential thrombocythemia, the rates of transformation to myelofibrosis is only 4% at 10 years, and to AML is only 1% at 10 years. While the rates are slightly higher for PV, they're still quite low. So the rates of transformation to myelofibrosis are 5% at 10 years, and to AML are about 2 to 3% at 10 years. And then survival is obviously something that people want to know. Any new disease, you want to know, is this going to impact my expected survival? So this is a study published in 2014 looking at long-term survivals, and as such it is also somewhat outdated, but we are lacking better up-to-date information here. I would expect survivals are longer now than they were in 2014, but the median survival in this particular study was 20 years for ET and 14 years for PV. But we need to keep in mind that the average age at diagnosis is 65 to 75. So when they looked at the subset of patients who were under 60 years of age, the survival was significantly longer. So it was up to 33 years for ET and 24 years for PV. And it is worth highlighting that a lot of what impacts survival is thrombotic events. So the better we get at managing thrombotic events, the better we get at managing survival. So on to essential thrombocythemia. So what will have happened to most patients diagnosed with ET is somebody will have identified that they have high platelets. And the first job that we have as clinicians is to make sure that we can outrule reactive causes, because any of us are entitled to have a high platelet count at some point in our life. So your doctor, if you have ET, will have first outruled iron deficiency, inflammation, infection, recent surgery or blood loss, all of which can push up your platelets. But when they've done that, then they look for the driver mutations. So as mentioned, JAK2 being the most common is the first that's checked for. It's positive in 50 to 60% cases of ET. If that's negative, we then go on to check for CALOR, and the last we check for is MIPL being the rarest. How do patients with ET present? Well, many have no symptoms, so they'll often just go to their GP or come in for an elective surgical procedure, and somebody will find that their platelets are far above the reference range. However, some patients do present already having had a thrombotic event, so some patients will present with a heart attack or a clot in their leg. Often they won't present with microvascular symptoms, but when they find out they have the disease, they'll realise that they do have symptoms that are microvascular symptoms. And microvascular symptoms refer to the very small vessels in our body that provide blood supply to our skin, for example, are impacted by the disease. So patients may have headaches, they may have numbness or burning pain in their hands or feet, they may have skin itch. Some patients with ET, particularly those with high platelets, may actually have bleeding symptoms, most typically things like nose and mouth bleeds, or for younger females, they may have particularly heavy periods. So essential thrombocythemia is diagnosed when there's a persistently high platelet count of greater than 450. It has typical bone marrow findings where when we look in the bone marrow, we see increased platelet production, and we don't see we generally see fairly normal white cell and red cell production, and importantly, no increase in fibrosis or reticulin fibrosis, because that would make it myelofibrosis. Importantly, then we look for the mutations, as mentioned. In the absence of those three mutations, it's a little bit more difficult to be certain about the diagnosis. So we have to make sure that before we diagnose somebody with triple negative ET or ET without a driver mutation, that we are certain that there's no reactive cause of high platelets, or in the guidelines they say that you can look for presence of a clonal marker. I won't go into detail on that, but that's just basically looking for evidence of genetic changes that may be related to the overproduction of platelets. So then, importantly, what do we do about it? You know, we now know that somebody has ET, but what can we do? So we stratify people into risk groups, and that risk refers to their clotting risk, because that's what we can modify. So high-risk patients are patients who are over the age of 60 or who have had a thrombotic or bleeding event thought to be related to their blood disorder, or a third criterion mentioned in the guidelines is very high platelet count of over 1,500. Treatment for high-risk patients is either aspirin, or if patients have a reason to be on an anticoagulant for another reason. So, for example, some patients may have atrial fibrillation and are on an anticoagulant for that, or if they've had a venous clotting event, they'll be on some form of anticoagulant. We then usually just have them on the anticoagulant and not on aspirin. It's rare that we need to double up, so most patients will be on one or the other. Then, because they're high risk, it's not enough just to have them on a blood thinner. It is recommended that we try and normalise the platelet count. So we do that with, it's called cytoreduction or cytoreductive therapy, and the usual first-line therapy is either Hydrea or interferon. Second-line therapy, if people can't tolerate the Hydrea or interferon, or if it's not working properly, we can move on to a second-line therapy, which can be either of the other drugs, or sometimes we use an agrolide. Then just looking at the non-high-risk patients, those are patients who are under the age of 60 who have never had a clotting or bleeding event related to their disease. Aspirin alone is sufficient with monitoring of the patient, as well as management of any cardiovascular risk factors, because although thrombotic events are the big concern here, they're not exclusive to patients with MPNs. Lots of people have heart attacks and strokes for lots of other reasons, like diabetes, smoking, high blood pressure, high cholesterol, and these are all things that all of us should be modifying if we can. So all patients should have their cardiovascular risk factors managed. And I just mention here that aspirin can be, we don't necessarily have to give aspirin to non-high-risk patients who are JAK2 negative. I'll speak a little bit more about that in a moment. Sometimes patients that aren't technically fulfilling criteria to be high risk are still considered for cytoreduction. And those would include patients who are particularly symptomatic of their disease. So for example, if they have splenomegaly that's causing them discomfort in their left upper part of their abdomen. If they have severe microvascular symptoms that are still there when they start taking aspirin, so if people still are quite itchy or have headaches that we think are down to the ET, sometimes then cytoreductive therapy is started, or uncontrolled bleeding with high platelet counts. So I just want to mention, without bogging us down too much, that most of the kind of guidance that I'm referring to here would be standard European guidance that most of us would follow within Europe. There is this prognostic score that was developed that further subdivides people. As I mentioned, I'd said kind of high risk and non-high risk. This prognostic score further subdivides people into 4 groups. And the main difference between this and what I've already spoken about is the recognition that JAK2 positive patients and JAK2 negative patients can't necessarily be lumped in together, because we do know that the JAK2 mutation is more prothrombotic than other mutations. So basically on the next slide, I'll just mention this. This is some American guidance. As I said, it wouldn't necessarily be standardly what people would follow in Europe, but I just want to acknowledge it, that for patients who are low risk because they're under 60 with no prior thrombosis, but if they, in addition to that, also are JAK2 negative, we don't necessarily have to use aspirin. The evidence for starting aspirin in that patients is not very strong. And similarly, patients who are over the age of 60, who would have previously been put in the high-risk category, if they have no prior thrombosis and also are JAK2 negative, this particular guideline would say that no cytoreduction is needed if asymptomatic. That is not generally what is followed, but I just want to mention it because it is guidance that is available and followed in some places in the US, for example. I suppose my point is that the evidence is not as strong necessarily for what we do in the JAK2 negative patients as it is for the JAK2 positive patients. Just briefly to mention, because some patients ask me quite a lot about what their mutation type means. As mentioned, JAK2 positive patients have an increased risk of thrombosis and seem to have a lower risk of post-ET myelofibrosis transformation. When we look at patients who are CALOR mutation positive compared with JAK2, they seem to be younger, more male patients, higher platelet count, lower hemoglobin level, lower white cell count, and a lower incidence of clotting compared with JAK2 positive patients. And then this is fairly small print stuff, but this is stuff that I have been asked by patients who want to know their specific CALOR mutation type. The first thing to mention is in Ireland, in our national molecular lab, they don't routinely report out to us the subtype of CALOR. So when patients have asked me about their subtype, I've then contacted the lab directly to get it, because it is available but not routinely reported out. As I mentioned earlier, at present the subtype of CALOR does not alter what is recommended that we do for patients, but CALOR type 2 patients seem to have a higher platelet count compared with type 1, and type 1 patients may have a higher rate of transformation to myelofibrosis compared with type 2. So, on to polycythemia vera. So just to give us a little bit of context what I'm talking about here, A lot of us, with our routine bloods where our GP will be used to hearing the term hemoglobin. So when our hemoglobin goes low, that's known as anemia. But actually in the MPN clinics, what we tend to focus on is a thing called either the packed cell volume, PCV, that's what we call it in our lab, or some labs will call it hematocrit. They're interchangeable terms. And what that refers to is the percentage of your total blood volume that's made up of red cells. So you can see our blood contains this liquid component called plasma, a small amount of white cells and platelets, and then a lot of it is made up of these red blood cells. It should be under 49% of our blood volume for men and less than 48% for women. When it goes above those thresholds, that's when we start to wonder if there could be something driving overproduction of red cells. So, same thing as with high platelets. When we get this abnormal blood result, we consider, are there reactive causes here? The most common cause of these high red cells is actually smoking, whether it be current smoking or a history of smoking in the past, but equally any other cause of low oxygen, so people who have lung disease or obstructive sleep apnea, or even actually if people go for their bloods while they're dehydrated or fasting, it's not that they have more red cells, it's that the liquid component is less, so the percentage made up by red cells is more. So these are reasons why people might get a particularly high packed cell volume. So we would repeat it and look for reactive causes, but if we truly think this person is making more red cells than they should do, then the next step is to look for the JAK2 mutation, because it is found in over 95% of cases of polycythemia vera, so it almost always clinches the diagnosis. Other blood tests that you may have heard of in attending your haematology clinics, so the serum EPO or erythropoietin is another blood test that we check. Just to mention, this is a hormone that is made by our kidneys, and it instructs our bone marrow to make more red cells. So it gets we make more EPO in response to situations where our oxygen levels are low. And when we check it in PV, it's usually suppressed, it's usually low. So it helps in those situations where we're trying to differentiate between whether this is a high red cell due to a bone marrow condition versus due to something like smoking or another cause of high red cells. Then in the rare situation where the JAK2 V617F is negative, we can go on to check for the rarer exon 12 mutations, which are found in fewer than 5% of cases of PV. So the presentation, somewhat similar to ET. Some patients have no symptoms. Some patients, unfortunately, present having already had their first thrombotic event. Many patients will have redness of their skin or their face. Sometimes they won't have noticed it. Often their spouse will have noticed it, or perhaps their family members. Often when you discuss with them, they'll recognise actually that they're more fatigued than they previously were, or sometimes more irritable. Similarly, they can have microvascular symptoms like headaches, blurred vision, numbness, burning in the hands and feet. A very typical feature of polycythemia vera is a thing called aquagenic pruritus, which you will probably have been asked about if you have PV, which is where you develop skin itch, particularly after a warm bath or shower. And some patients who have an enlarged spleen may have fullness or discomfort in the left upper part of their abdomen where our spleen lives. So polycythemia vera is diagnosed, as mentioned earlier, if the packed cell volume is over 49% for males or 48% for females, or the hemoglobin is over 16.5 for males or 16 for females, and they have either a JAK2 V617F or a JAK2 exon 12 mutation. They also will have typical bone marrow findings, in which usually it's not just increased red cell production, but when we look in the bone marrow, we see increased production of cells across the board, or they will have a low serum EPO. We risk stratify these patients. We risk stratify these patients in a similar way to essential thrombocythemia. So being over 60 years of age or having had a prior thrombotic event puts you in a high-risk group. Everybody else is considered low risk, but nothing's ever that straightforward. So you'll see here I mentioned that some low-risk patients may be considered to be at higher risk in the presence of other risk factors. And I'll speak a little bit about that in a moment. So the management of all patients with PV is we want to get their hematocrit or packed cell volume down below 45% or 0.45. We can achieve that by venesection for low-risk patients, but it is recommended that we achieve it with cytoreduction plus or minus venesection for high-risk patients. Patients should be on low-dose aspirin or on anticoagulation if they have a reason to be on anticoagulation. As same with ET, we usually don't need to have somebody on both an antiplatelet and an anticoagulant because it increases their bleeding risk. We manage their cardiovascular risk factors. For high-risk patients, as mentioned, we cytoreduce. So the first line is hydrea or interferon, and the second line is either ruxolitinib, hydrea, or interferon. So just to mention, there may be some low-risk patients where cytoreductive therapy has been recommended, and those would be patients who have additional risk factors for thrombosis, such as other cardiovascular risks, high white cells, difficult to control packed cell volume, high platelets, or particularly symptomatic patients. So in conclusion, ET and PV are disorders caused by as yet unexplained acquired genetic mutations. Symptoms and complications are very varied. A leading cause of morbidity and mortality, or complications, is thrombosis, but this thrombotic risk is modifiable with how we manage their disease. Once the thrombotic risk is managed, survival is excellent, and the risk of transformation is low and not currently modifiable with treatment strategies used nowadays. Thank you.
Thank you so much, Aisling. And you had a big topic to cover, and I think you covered it really, really well. And I'm sure a lot of people will have learned a lot. Our next speaker, I am delighted to welcome Professor Claire Harrison from London. And she's going to talk about new treatment opportunities. Welcome, Claire.
Thanks very much, and thanks for the opportunity to stand in front of all of you today, and thanks for coming. It's such a beautiful place. I'm definitely coming back. And thanks, Aisling. That was really an amazing presentation. I think 20 minutes to cover 2 diseases, and I get the same amount of time just to talk about new treatments. We're a little bit out of order in terms of how we would normally cover topics today. So I'm going to be talking about some things that are new before we're talking a bit about what's current for myelofibrosis. Sorry about that. That's fitting around my family commitments. This is another way of looking at Jack. This person is Janusz. He's the Roman god. And he is the person that Jack was named after, but otherwise, actually it was also called just another kinase by the person who described it. Janusz is the god who holds the key to metaphorical doors or gateways and the gap between what was in the past and what's to come. And what we haven't had time to talk to you about today is how much this field has changed since the description of those mutations and the discovery then of drugs which can block the downstream effects of those mutations. And we'll be talking about JAK inhibitors a bit later in my slides, and Claire Andrews will be talking about it when she talks about myelofibrosis. But we might now be on the verge of another big shift in how we treat MPNs targeting calreticulin, which Aisling's spoken about. So I'm going to talk a bit about ET and new drugs for ET, some new data for PV, and touch very quickly on new approaches in myelofibrosis before giving you a glimpse of these new therapies. We already talked about ET, and we already covered, Aisling already introduced to you, that there's some divide in the field or a little bit of uncertainty about whether we should really be treating patients with different mutations in a different way. So what she presented to you was that the risk categorization is a bit different, but actually we tend to say if you're over 60 and or you've had a blood clotting event, you should have a treatment regardless of your mutation. And treatment is usually interferon or hydroxycarbamide, and sometimes a drug called anagrelide. There are some new drugs to tell you about that are coming in ET. One of them is a drug called bomedemstat, which inhibits LSD, not the same as LSD, the psychedelic drug LSD, but something different. And that will come in a study as a new treatment, but also for patients who are struggling to get good control of their platelet count. There isn't a pointer here, but what you can see on the right is a platelet count coming down with that drug. You can see that the white count doesn't really change and patients don't get anemic, which is important. And we saw when we measured symptoms that fatigue got a bit better with this drug, which is important because we know that many of you patients struggle a lot with fatigue. We're going to come on to driver VAF, and I'll decode that for you a bit later. There are studies with this drug coming, and they're also planning to look at it in PV. At the European Association of Haematology meeting in Frankfurt a couple of weeks ago, another drug was described which looks effective at managing PV, which is called pelabresib, which inhibits a different group of molecules called the BET molecules. It's really exciting to have 2 potential new treatments for ET because we haven't had a new treatment for ET for a while. But this is all really, really early data. And most patients with ET do well with one of our current treatments. So you can see the same thing on the left, the platelet counts coming down, the white count staying about the same, and the hemoglobin definitely not dropping, which is good. And looking at all of the different symptoms that were measured, and sorry, you won't be able to read that, but at the top was improvement in numbness and tingling, which some patients get because of platelets sticking together, or unintentional weight loss, or itching, which is really very difficult for some folk. And we also saw some reduction in driver mutations, and more of that in the next few slides. Those of you, how many people here have got PV? Quite a few of you, yeah. So this is Henri Louis Vacquez, who first described PV. He's a Frenchman with a rather fantastic moustache, and it used to be known as Vacquez disease. And he described the condition in a 40-year-old. So you heard that on average, patients are in their mid-60s usually, but around 20% of our patients are under 40 at the time of diagnosis. So, and it's interesting that he first described this disease in a 40-year-old. Here, the JAK2 mutation is by far the commonest mutation, and we know this is really a JAK2-driven disease, unlike ET, which is about 50-50. Here, we've been studying interferon, comparing it to hydroxy, and I know a lot of people that I see in my clinic really agonise about that treatment choice, but in reality, it's about what treatment best suits you. And many times there have been attempts to do study. Mary Frances and I have tried to do a study starting in about 2001, comparing these 2 drugs. There is a study that shows perhaps that interferon-treated patients have less complications, but there's a lot of discussion about whether that is really meaningful in that study. I want to talk to you about this trial called MAGIC, which was a study looking at ruxolitinib, which is a JAK inhibitor in patients with PV. Now, I know in Ireland, patients with PV can get access to ruxolitinib, and that happened after some studies that were done supported by Novartis, the drug company that market ruxolitinib. But in England and in Ireland until recently, patients couldn't get access to that drug. And so we did what we would call an academic study, so done by doctors and scientists with funds from charities like MPN Voice or Blood Cancer UK, etc., and the support of Novartis, who gave us ruxolitinib for free. And free ruxolitinib for 100 people for over 5 years is not cheap. It was a huge amount of support. In this study, we have got some recent findings which are important. First of all, we found that ruxolitinib was good at controlling the blood counts, but if you look, you might not be able to see it over this beautiful book, but here we found that patients who were treated with ruxolitinib had fewer events like blood clotting, their disease changing, and there were fewer deaths. For a long time, there's also been this question mark about how important is it to have a normal white cell count and a normal platelet count if you have PV. And this has been argued backwards and forwards for decades. In this study, what we found was, this is something on the right-hand side here, If the patient had a normal white cell count and a normal platelet count, again, they had less chance of having a blood clot or bleeding or their disease changing. So that's important, and it's an important take-home message. You probably all get your blood counts checked. Have a look and make sure it's normal if you're taking a treatment. And if it's not normal, have a discussion with your doctor. There's probably a reason why maybe we're not targeting a totally normal count. So, and then I want to talk to you about molecular analysis with a warning. So, incoming medical jargon, all right? And the jargon is something called JAK2-VAF. JAK2 is the mutation. VAF stands for variant allele frequency. That probably doesn't help you. But what that really means is the percentage of your or the patient's JAK2 that has the mutation. So if the VAF is 100%, it means that all the JAK2 genes are mutated. If it's 50%, then it's half. And it's performed as a blood test. And sometimes when you have those gene mutations tested for, they're expressed in this way. Sometimes not. And for diagnosis, that's not so important. In some blood cancers, it has become apparent that measuring how much disease mutation there is important for predicting outcome for a patient, but that has never been the case in MPN. In the MAGIC study, we did an analysis and looked at how many patients had a 50% reduction. So if they started at 80, their VAF went to 40, or if they started at 50, it went down to 25. And what we found was a couple of things. One, that this was more common over time with ruxolitinib, so that's the blue part of this plot. And when we looked in the stem cells, this was some work done by a very smart doctor from Cork called Jennifer O'Sullivan, who's been working in London and Oxford for a while. In the stem cells, we found that the amount of JAK2 disease cells was also dropping. So what? But what we also found was that patients who had those reductions in the clinical trial had less clotting, bleeding events, less chance of transformation, etc. But remember, we also showed that with ruxolitinib treatment, and we also showed it by controlling the blood count. So that means that there's a question about whether we should be looking at this, and Mary Frances actually was debating this in Germany recently with a French colleague. It was a very close debate and very well done. So we're not sure at the moment, and that's kind of summarised on this slide. Should we begin to think about doing this? It's really an experimental tool. I'm not doing it all the time for my patients in London. Probably patients nearby in Limerick or in Belfast or Dublin maybe also not being done, but we're looking and thinking about it in the field. We are going to do now a study called Mithridate, which hopefully will finally get open in Belfast, comparing ruxolitinib as a first-line therapy. The MAGIC study was done for patients for whom interferon or hydroxycarbamide wasn't working well. Just to talk to you about another drug that is being tested in PV, this is called rusfertide, and it's something called a hepcidin mimetic. And basically what it does, if we can go forward with the slides, is it blocks the release of iron. So it does the same as having blood taken off. It reduces the amount of iron that's available, and it switches down red cell production. And in a study where patients were treated with this drug and then it was withdrawn in a randomized way, we found that that treatment reduced the need for bloodletting or phlebotomy. So that could be a useful treatment that might come to reduce the need for phlebotomy, which is important because it takes a lot of time and it causes issues like iron deficiency, etc. So we just click over that. And now I want to just take a few minutes to talk about myelofibrosis. How many people in the room have got myelofibrosis? Okay, so a few of you, great. So this is a picture of one of our patients in London who is treated with ruxolitinib or Jakafi, which is the first JAK inhibitor, which has been available now for 10 years. This patient had a very big spleen. That's what the green thing on the left is highlighting, which reduced on the drug, and it improved her quality of life. Her energy got better. She wasn't itching as much. She still had the disease, but it made a big difference for her. But what we know is that some patients ultimately lose their response to that drug. What we're still trying to understand is why and what can we do about it. And we've been studying that. So here's an example of a study that was presented in an American meeting. Lots of fancy science here. Lots of what we call heat maps. But in the basic message for you is we don't 100% understand. It's still a work in progress. But we know that some patients can have a really good response to that drug that lasts a really long time, and for other patients, it doesn't work as well. But the good news is that we have lots of other JAK inhibitors potentially available. We have a drug called fedratinib, which is similar to ruxolitinib, but slightly different targets. We have a new drug called momelotinib, which does what ruxolitinib does, but improves anemia. And then we have another fourth JAK inhibitor called pacritinib. We all have to practice these names, which is specifically being developed for patients with low platelets. But these are only the backbone, really, of our treatment, and we're only beginning to really understand how to move forward with these drugs and combine the JAK inhibitors, which is what's on the top right of the slide, with multiple other agents to target other problems in transplant, in myelofibrosis, which can also be treated with transplantation. So our question is, and something we're looking at trying to address at the moment is a one JAK inhibitor enough? Should we add another drug? And Mary Francis is leading a study looking at adding interferon to fedratinib. And should we do that at the beginning, or should we wait until the patient is starting to lose their response to the JAK inhibitor? And one of the problems we've got is, how do we define success? So again, that VAF terminology or technology might be useful for that. So I think that's probably now just leading quickly in 1 minute to the last part, which is to talk about this new therapy. I put that picture of Janusz up, and then I said we might be coming to something new, and this is the something new we might be coming to. So who in the room's got a calreticulin mutation, if you don't mind saying? Yes, at least one? One or two or three? Yep. So your calreticulin comes out of your stem cells, and it binds on the outside of the stem cells to a receptor. That's what's being shown in the middle of the slide. And that's how we think it triggers the disease. And recently, an antibody, like the antibodies that were developed by COVID vaccines, for example, has been developed, which recognises the abnormal part of calreticulin, this red bit, which isn't there on normal calreticulin. So the idea is that that antibody or a targeted immune system can then get rid maybe of calreticulin, and that's what we're starting to see in the laboratory. On the right-hand side, we started to see more cell death. Those are the blue bars going up as we use that antibody. We started to see a reduction in the number of mutated platelets. And in the bone marrow, so this is a mouse bone marrow, not a human bone marrow, and the big brown blobs are megakaryocytes or platelet-producing cells. And you can see there's a difference. On the left is a mouse treated with just a dummy control, and on the right is the mouse treated with this antibody. So you can see that there's a reduction in the brown blobs or megakaryocytes. So we are starting now to have trials where we're using this type of treatment for patients with calreticulin disease. We don't know how it's going to work, but we will be starting those treatments for patients with ET and myelofibrosis. So I think it's really exciting, and I look forward to coming back in a year or so and telling you how we're doing. Thank you very much for your attention today.
I think you'll agree that was a really, really hopeful talk, that there's so much for us all to look forward to in treatments. Our next speaker is candidate advanced nurse specialist, Sarah Connolly, who's been really working with us right from the beginning, and delighted to welcome you onto the stage to talk.
Thanks a million, Nona, and thanks to MPN Voice for including me in today. It's so lovely to see a great turnout. I'm Sarah Connolly. I'm a candidate advanced nurse practitioner in haematology in Galway University Hospital. I am new in this current position since January, so it's a work in progress, but 23 years in haematology in total between the UK and in Ireland. So I'm just going to do a quick rundown on the management of the common MPN symptoms. Obviously on this slide there's loads. I'm going to go into quite a few of the most common ones. You know, there's headaches, abdominal discomfort, you know, the financial strain of having a chronic illness, fatigue, spleen discomfort, depression, bone pain, etc. So the goals of MPN treatment considerations should include reducing the symptom burden as well as improving quality of life and productivity to enhance the overall health and lives of patients living with an MPN. I'm going to go through the landmark study, which was a study that included patients with polycythemia vera, essential thrombocythemia and myelofibrosis. It included questions on overall disease burden, quality of life, activities of daily living, and work productivity. And it was an international survey online for patients and physicians, which included Australia, Canada, Germany, Japan, Italy, and the UK. So as you can see, 699 patients were surveyed and 219 physicians. There was quite a big number of UK patients, 286. Now this slide, it's not very clear, but it just shows what were the symptoms that did come up, and fatigue was a huge thing. It came up a lot, and abdominal discomfort and what have you. 90% of patients experienced symptoms and reported a reduced quality of life, main symptom being fatigue and tiredness. Many in each disease group reported feeling limited by pain or discomfort. Most respondents reported feeling anxious or worried about their diagnosis. Limited productivity, including having to reduce working hours, calling in sick, some terminating jobs. And women reported a higher symptom burden than men. So the myelofibrosis cohort had the highest symptom burden. 26% of all patients stated that their diagnosis caused emotional hardship. 89% of patients were worried about that their condition may worsen. And I think that's in all MPN patients' minds. It's always at the back of their minds. MPN diagnosis impacted on employment, as I said, and work productivity. And the study suggested that certain drugs and therapies reduced symptom burden and improved the quality of life of patients. Fatigue, as I said, is a huge symptom and a debilitating symptom. And with fatigue, it causes decreased concentration, your lack of motivation to do your usual stuff, you know, decreased or disturbed sleep, you know, your limbs are heavy, you feel weak. And also when you're tired, you do feel your emotions are really exacerbated. Things can seem more emotional than normal as well. And trouble completing your daily tasks due to short-term memory problems, and the impacts on the activities of daily living, as I said, affects relationships with work, family, your social life. So why is fatigue very difficult to talk about? As I said, it's just not very easy to measure. Only the person experiencing that symptom can really tell you how they are feeling. And it's sometimes difficult for patients to offer a specific explanation about their fatigue. And there's no quick fix or no quick solution sometimes, but even sometimes the small suggestions may help. Now, acknowledgement, the first major step is to listen. and the first step towards assessment and management of this symptom. So, what I do suggest with managing fatigue is education, planning your day, prioritising your day, do the tasks that you feel that need to be done, pacing yourself, and also giving yourself that permission to be tired, and to rest. I do find patients that keep a diary is really helpful for us in clinic, to see the trend of how you have been in between clinic visits. Regular exercise is always good, and address any anxiety issues that's going on. You just don't know what's going on in people's lives, Relaxing before bed, trying to get up at the same time every day. As I said, making time to relax. Yoga and meditation is quite good. I know they did a yoga study in the US on its benefits for MPN patients. Limit alcohol intake, good diet and good fluid intake. And also, know you can say no. It's okay to say no. Don't feel pressurised into things. And talk to family, friends, talk to your nurses, your consultants about how you feel. The famous itch, pruritus. As I said, it is a huge symptom. As I said, it is like an itch that makes one want to scratch continuously. So itching occurs as a result of the cytokines, the small proteins involved in the cell signalling associated with your disorder. And this can be caused by the mast cell releasing a substance called histamines, which causes this itching sensation. I had a patient there recently who said he was outside the gable of the house rubbing his back up and down against it because it was driving him mad, and his wife didn't know where he was. But anyway, the majority of patients find this symptom worse, especially post a shower. So what I would avoid is to avoid too hot of a shower. Pat dry the skin. I do find putting your body cream in the fridge, simple things like that can soothe things. Some patients may need to take an antihistamine to try and help these symptoms. Avoid certain fabrics that irritate your skin, and avoid triggers if you had sensitive skin to begin with. Now, some patients, I haven't come across anyone really yet, have had needed treatment with UV light, and there are drugs such as paroxetine and aprepitant for severe cases. Microvascular symptoms. These symptoms are caused by raised blood counts, headaches, dizziness, tinnitus, numbness to the hands and feet, secondary to erythromelalgia. You might find you have redness or burning sensation of the hands and the feet. In essential thrombocythemia, it's the increased platelet count that causes these microvascular blockages in the blood vessels, and in polycythemia vera, it's the raised red blood cell count, the hematocrit, that causes the blood to be more viscous, more thick, and reduces the rate of blood flow into the capillaries, causing these symptoms. Risk of thrombotic events, which was touched on earlier, but as a patient you need to be aware of that risk, to look out for signs of pain, swelling to the limbs, acute shortness of breath as well, and things to help that and is to stay hydrated. There are days where you're going to be wrecked, and I always say to patients, please do get up and mobilise a bit. Also to wear flight socks on flights at all times. Brain fog, lack of concentration, feeling exhausted, difficulty making decisions, taking more time to complete your tasks, losing your train of thought, slower to process information, and trouble keeping up with long conversations. If you're out socialising in the evening and there's big conversations going on, some patients are just wrecked and can't keep up. I do advise exercise daily, regular walks, yoga, mindfulness and meditation. Try and avoid stressful situations as best you can. Regulate your sleeping pattern, trying to go to bed around the same time every night, setting your alarm in the morning, pacing yourself, mental exercises, crosswords, reading, Sudoku, all these things are quite good. Plan your day, have a routine. Healthy diet yet again, and keeping hydrated, and to ask for help. And sometimes your medication may need to be reviewed also. Night sweats can be a huge issue too, and it could be sweating during the day as well. It's not just always at night. I do advise patients to have a fan, sleep with the window ajar, air conditioning. I do find some of the cold packs, if you put them in the freezer and take them out at night and put them under your pillow, do help you as well, cool down. Avoid spicy foods, cigarettes, alcohol and stuff like that before bed. Cotton bed sheets are usually better, and some patients find sleeping on a bath towel, helps. Pain. Pain can be from the bone pain caused by your condition, the proliferation of the blood cells, and you can have some abdominal pain, especially if you have splenomegaly, a big spleen. Emotional impact. This is huge for patients. The anxiety and worry. You've been told you have this diagnosis, this is a chronic illness. And also, you worry about your prognosis too. I know we touched on earlier the percentage of patients that transform. Some patients, even though it's just a minor percentage, worry, think, what if I am in that percentage, And I think that is always at the back of patients' minds. The financial impact, coming to hospital, trying to get parking, it's the stress of all of that. Having to take a day off work, the financial worries. 61% of patients in the landmark study experience depression. The unpleasant symptoms affecting quality of life, feeling of loss of control can be huge. 1 minute you're plodding along, everything's going great, and next thing you're told you have this myeloproliferative neoplasm. And it can be a lot to digest, sometimes starting new medications, and that feeling of loss of control. Problems maintaining relationships, worry about changes of treatment, worry about pregnancy and fertility issues. Also, it's not just the diagnosis, it's also the medication that can come with it and all its side effects and the worries about different side effects and how to manage them. And adapting and living every day with a chronic illness. So the MPN 10 symptom tool, I'm just going to quickly go through this. This is fabulous. It's useful for tracking symptoms and monitoring your progress. It enhances patient and medical team communication and consultation. It's educational. It's very easy use. Some of you may not know me. Since I've been in position, I've been starting to use this tool and I'm finding it brilliant. It's easy to use. It also gives patients an active role in managing their own care. And also, as you do the assessments every so often, you can see how you may be getting better. Symptoms are slowly getting better. And the symptom severity is measured using the 1 to 10 severity scale. Now, this is just the assessment form that I use, where you put your name, the date of the assessment, and all the different categories. As I said, 1 being hard, nothing, and 10 being really severe, and like 4 or 5 where you're kind of middle of the road. So the symptoms that we look at is fatigue, early satiety, in the fact that feeling that when you eat, you get full quite quick. Abdominal discomfort, inactivity, problems with concentration, night sweats, itching, bone pain, any temperatures or fevers, and any weight loss in the last 6 months. These are the references that are quite helpful in me developing my talk today. And I have an email address, and that is it. And I am contactable through the hospital switchboard. So if I don't answer there and then, you can always leave a message and I will get back to you. So I'll just thank you all.
That's really, really great, Sarah. Thank you so much. This is an exciting part of the day. We are joined by Dr. Janusz Krawczyk from Galway Hospital, and I'd like to welcome him to the panel. This is the panel Q&A. You are free to ask questions, and I have to remind you, not personal treatment plans. And Professor Harrison is going to chair the panel because she will choose which question goes which way. So Claire, over to you.
Yeah, that means I don't have to answer any of them. That's all good. Okay, I'm just wondering, for the sake of Aisling and Claire, is it possible to just turn the slides off? Just because, yeah, it's the slide projector. It's probably straight in their eyes. So not only are they going to get tricky questions. So there are some questions that got submitted on paper, but also there are people walking, and there's only two. So there's going to be two long answers to two questions, if that's all we have. So maybe we'll start with some of the questions that are written down here. And the first question is really pertinent, I think, and that's about fatigue. So we had a lovely talk from Sarah about fatigue, but I just wanted to ask you all a question before passing this question on, maybe to Sarah, and then maybe also to ask a colleague to answer as well. How many people in the audience would say they suffer with fatigue because of their MPN? Almost everybody in the audience, yeah. Okay, so this is really a question from most of you, probably, but you can also volunteer an answer to this question if you want to, or this is the kind of thing that could be discussed in the breakout sessions later. So there's two questions. The first one I'm going to ask to Sarah, and the next one I'll ask a colleague to volunteer to see if they want to answer it, or Sarah can. How best to explain fatigue to family as they feel they can't understand, and they often make a comment about maybe you should just eat more and it will get fixed. So Sarah, maybe you could take that question first.
Thanks, Claire. That's a really good question. It is very difficult to try and explain to a family member. And also fatigue, you never know when it's going to happen, when you're going to be floored. Sometimes you're constantly fatigued. Sometimes it helps if you bring a relative to your clinic appointment, or if you bring a relative with you to speak to your clinical nurse specialist or your advanced nurse practitioner. But it's also good for patients to show relatives. The NPN Voice fatigue leaflet is very, very helpful about tips and what have you. So yeah, it's if you're having problems explaining it, I know myself as a nurse would have no problems explaining to your relative on your behalf either. But as I said, it's very difficult to assess fatigue. It's very difficult to manage fatigue, and very difficult to explain it. Does that answer your question?
Yeah, I wonder if Claire, maybe you want to comment as well, and Aisling. And then the last bit of this question was actually about how to combat some of the lack of awareness or ignorance. So it's not only for family members. I think it's often a case about employers as well. That can be an issue. So
yeah, I agree with everything Sarah says. I think really it's really important that family members actually come to the clinic and really understand. Because first of all, you have your disease and you have the tiredness that's associated with the disease. And then we also give you medications, and some of those medications can also make you feel fatigued. As a doctor, the first thing we do is we make sure there's nothing else that's causing fatigue. So for example, sometimes your hemoglobin goes down and that can make you fatigued. So having a family member coming in with you and really understanding the disease itself, the toxicity, and the psychological impact, obviously, as well, because we were talking a little bit about younger people. It's very hard to tell somebody at the age of under 40, whatever an age is, that you have this blood cancer. So that psychological impact and the worry that goes with it. In terms of work, certainly, I have often written letters, and work really do need to, from a HR perspective, once a letter is written by a doctor, they actually aren't particularly, if you have a letter written for clinics or anything like that, and we can support you. But the point is, if you are having issues, talk to your doctor, talk to ANP, the ANP, the nurse, and we can certainly, because we've seen all these issues before. It's usually something that we're very familiar with. So certainly talk to us and the team.
I suppose I just wanted to say, having Sarah speaking today, I know this is for us to kind of try and maybe educate others, but also I find forums like this that I get educated. So as a doctor, quite often I am focused on the medicines, and when I go to these meetings, I'm looking at what are the new drugs, and when the patient comes into my clinic, sometimes, and it's not a nice thing to admit, but sometimes I'm not good at focusing on the things that I can't help with. So I sometimes feel like I can't overly help with fatigue. So I kind of brush past it and I say, oh, the bloods are good and the spleen is good. So it's really nice when I hear the focus of an ANP, and I spoke at the nurses HAI meeting last year, and similarly, just to hear a different perspective, that it's not all just about the doctor's care, that actually we need to work as a team. Our nurses are really critical, and they see things and have strengths that I don't necessarily have. So I think that's really important for us to remember. And I think it's how we move forward with management of not just MPNs, but a lot of the other diseases we deal with, is that rather than just treat it as a medical condition to be managed medically, that there are lots of other aspects to it, psychological, holistic, dietary, that I can admit that I'm not great at focusing on, but then I don't have to on my own, that we do need to work together as a team. So I'm really grateful for your talk today, and I'm really grateful for how we are kind of expanding in Ireland. Like, we have a new ANP in the recent past in Limerick for who's helping with the MPN clinic, and I have a dedicated CNS in the MPN clinic, and I think that setup is the way forward.
Well done. Totally agree. So look to the team. The other thing is to look to the community. So talk to each other. And be glad, because actually UK and Ireland, I think, are the only countries that have clinical nurse specialists and ANPs. So you, as patients in our communities, have that benefit. So do use their expertise and their way of supporting you. So if you need a letter for your employer, that's where to go. Great. Anybody from the audience want to comment on fatigue or make a comment at this point? Yeah, great.
Hi, how are you? My name is John Burns, and I'm a patient of Dr. Nee. I suppose the first thing I want to say is, anybody in the room, please do not make excuses for your fatigue. That's first and foremost. Probably most of us in the room have been fixers all our lives, and we've been doing things for families, friends, work colleagues. You don't recognize that till you are where you are today. And you look back in hindsight. Hindsight's a wonderful thing. We all learn from that. And we go, well, why did this, and well, why did that, and well, whatever. But you got to put yourself front and first and foremost. Don't worry about whether your family understands your fatigue, whether your partner, your husband, your wife. That is not the issue here. The issue is about you staying well and being positive every day, and put all your energy into that. Because otherwise, you're going to go to the doctor whenever your visits are, let it be once a week, once a month, once a quarter, whatever way it works, and you're worrying about your visit, and then you're worrying about how you keep everybody else happy. Now, this is not a case of just chop everybody off. This is a case of put yourself first and say, listen, no, I can't do this anymore. I actually don't have the energy to do it. I have to focus on other things right now, which is me, my life, and sustaining myself, because guess what? I want to be around here for a long time. That's what. Don't make excuses for your tiredness. And don't be afraid to say it. And that's that. I think that's just the simple message of it. That's it.
Great. Thank you very much for speaking up. That's great. And I know you've come with a big team today as well, which is grand. Question over here.
I know, I was going to say I totally agree with that gentleman, but that's all very well and good. But when the people that you're saying that to don't listen, then what do you do? And you need the help and everything. What do you do?
So then that's when I think actually talking to the clinical nurse specialist, but there's somebody else who wants to make a comment. And sometimes we're not all brave enough to speak up. So sometimes we need a bit of coaching about how you would describe it, etc. Please go ahead.
Hiya, I'm Brian. I've got diagnosed last December PCV, but there is a difference between tiredness and fatigue, and I think the best way for me to describe, geez, my voice sounds weird, is that I got a fatigue episode, I think, a couple of weeks ago, and I just lay down, and I suddenly became an animated character, and I saw my energy levels, like in a battery on a phone, go from 100% just going down and down and down to about 8%, and then you were just functioning at that stage. Now, once I have my 20 minutes, 40 minutes, I'm grand, but I'd say the best way to explain it is that you have a sink full of water, which is energy, and rather than it just drip feeding out, you're pulling the plug and it's gone, and there's very little left.
Thank you very much. Actually, if you take a look at some of the literature on fatigue, there are lots of different ways that people describe it, like having your legs in concrete, like somebody suddenly pulled the plug. So I think these kind of ways of describing are really good. Anybody else want to make a comment? I have got another question I can read out. Yeah.
Is it a trigger for help when you feel numbness in your arms, your feet, your legs, and itch as well?
Mary Frances, did you hear that question? I think is it a trigger for help if you feel numbness around your feet and legs and itching as well? I'm going to give you the mic.
I think that depends, really. It's a question for perhaps raising with your doctor. Itch is something that we've talked about is very much part of these diseases. Numbness in your feet and legs, I would take that to your doctor and get them to look at it, because it could be lots of other things as well. I mean, basically, in general, anything new that you haven't had before should be raised, is that an issue? Even if, say, no, that's okay, but, you should raise it and see if this is something that we go, oh, yeah, we need to think about that.
And I think if there's anything new, even if you don't have one of these conditions, that kind of symptom you would want to speak to your doctor about. But if you're not sure if it relates to your MPN, the nurse is your first call often. Would you agree?
Yes, that is what our roles are as a clinical nurse specialist or an advanced nurse practitioner. Any of these queries, do contact us. And if we can't answer, we always can run things by your individual consultant. Okay?
Great. Well done, Nona. You're getting your steps in today.
This is a question that's not really related to the previous WH. Is that okay?
Of course. Yeah.
I just wanted to ask, because I'm a member of a Scandinavian informal support group on Facebook for PV, and a substantial number of people have got the double diagnosis, PV and fibromyalgia. So what comes up in what you talked about is the bone pain, and I have a lot of pains which I can't relate to exactly bone pain, and I was just wondering, could it be, and I'll leave the question with you, I'm not expecting an answer, but are these if that many people get double diagnosis, is it just one?
Anybody want? Janusz, do you want to take that question?
I mean, not that all fibromyalgia is PV, but that if so many gets two,
I think the issue here is that sometimes with MPN, the symptoms are actually very non-specific. Especially us as females, I think the perimenopause and menopause period is also a difficult time, because also some of the symptoms of menopause are often similar to the symptoms of PV or any of the MPNs. In terms of fibromyalgia, I don't know if there's any data about fibromyalgia and PV, but you're right, you can with MPNs get these bone pains. So once again, you know, talk about with your doctor, see if there's some treatments that you can try, always bring it back to your doctor. But it's very non-specific, you know, and that's why it makes it difficult. But certainly talking to ANPs, but I don't know about any data with fibromyalgia and PV. I don't know, does anybody else know about it? But something we'll certainly look at. Yeah, yeah, it's and as Aisling was saying, this is what's great about these groups, is that as doctors, we learn from you, we learn from our nurse colleagues, and so certainly, thank you for raising that question.
Hello, I'm only a family support person, but it has been a little concern of mine for the last 5 years, say. I asked the consultants, do you put as much equal pass on the older patient, say 80 plus, as on the younger ill patients with the MPNs? Maybe I'm wrong, I hope I'm wrong, but I feel that the older person is sort of written off, should they're not long before they'll be gone anyway. Am I right? I hope I'm wrong. But is there a practice that the younger ones get more consultant time and attention? And it's a genuine question, it's not a complaint.
I think that's a good point. I can speak for our service and say, no, actually, every patient would get the same amount of time. And I'm sure my colleagues would probably speak up the same. We did have a little focus on younger people this morning because as a charity, we've had set up this new group. I think sometimes, actually, we need to give more time to the patients who need it. And often, actually, in my experience, I'll ask my colleagues to comment in a minute, actually my older patients, unfortunately, often have other conditions, and I do need to spend more time because sometimes you have to think about, can I give this medicine because they're already on that one? Can I take a pint of blood from this patient who's on lots of medications, maybe for their heart? So, and certainly I spoke about new treatments. Those treatments and those studies are open to patients regardless of how old they are. We can't take under 18s, but there's no upper age limit.
And is there equal access to the haematologist for the over 80s?
Yeah, absolutely should be. I'm going to ask, does anybody else want to speak? Aisling, yeah?
I suppose I would like to see every patient, every clinic, but that's not feasible. And so we have to, as I said, work as a team. Part of that's because I like the control of seeing every patient, every clinic, which isn't a good thing either. You do need to have a team around you. I feel that I dedicate more time at the start of a diagnosis. I think it's needed to have more face-to-face time with a consultant when at first diagnosis and when you're kind of developing a management plan and titrating medications. And then sometimes after that, patients may get seen by non-consultant hospital doctors or nurse specialists, and they may feel that they're not being kind of taken care of as well as they once were. I suppose I can't speak for other services, but I know for me, I look at every patient's, and I know bloods aren't the whole picture, but I look at every patient's bloods and every patient's case at every clinic. And so a lot of the care that we provide is not necessarily visible. So, for example, like I do certainly care as much about my patients over 80 as I do my patients under 80. Management is different for patients, let's say at 40 versus 60 versus 80 versus 90. It has to be, because we're not the same as we get older. We're not fit for quite the same things, and quite often the management plans need to be altered a little bit. But I certainly, in ways, worry more about my older patients. I certainly, in my time, because, you know, as we train, we work in lots of different centres. So although I'm now in Limerick, I've worked in Galway, I've worked in a lot of centres in Dublin, I've worked, you know, all around the country and overseas. And I have never, I don't think, seen a centre where people have written off elderly patients. But your management does change, and I can understand how it might seem as time goes on, oh, I haven't seen the consultant in some time. What I usually say, you know, the nurse specialist if they're seeing patients, or to the non-consultant doctors if they're seeing patients, if the patient has any concerns or they want to see me, let me know. I will have always made sure that I'm satisfied with their bloods and everything. But I think if you want to be seen by a consultant every once in a while, just voice that. That's okay. I don't think I can see how it could be perceived as maybe there being less care for older patients, but I don't think that's the case. I hope for everybody.
I accept that different practices are reflected in different centers, but from what we are doing in Galway, I can reassure you that there is no age kind of discrimination at any stage of what we do. The access to the services is driven by the patient's needs, and the patients, if elderly patients requires less kind of time, that's how it is. If older, more frail patient with more comorbidities requires more attention and more time, that's what we attempt, what we really intend to offer. Obviously, you know, across the country, we don't have as much resources as we would like to have. You know, I always say to the patients and my colleagues that per capita, per number of patients, we have 4 times less consultants than in other European countries. So unfortunately, this is reflected by the access to the services. But we always work the way that everyone should get access to as much as they require, rather than taking into account any other factors. So, you know, if you feel that your needs are not met, just voice it. Just mention this to when you see a junior doctor, and consultant will always see you.
I just want to echo the invisible work that happens. So, for example, I prepare my clinic. I decide who will see which patients, because some patients are more complex, so the senior registrar would see the more complex patients. Those registrars would then discuss those patients with me, and then afterwards we would talk about the patient. So although you mightn't feel that there is a kind of a seniority there probably is in the background, and there's a lot of that going on. But I absolutely voice, anybody. It often happens that a registrar will come in and say, oh, somebody wants to see you, and sometimes there's nothing wrong. They just want to say, I haven't seen you in a visit or two. Is everything okay? You say everything is okay, and that, So even if there's no problem, even if you don't have a particular issue, it's okay to be able to say, look, I wouldn't mind seeing the consultant. I haven't seen the consultant in a couple of visits.
Yeah. The other thing I think that's just come to me now, over COVID, we moved a lot of care out into, so in Limerick, I'm not sure what was done elsewhere, but in Limerick, we moved a lot of our consultations to phone consultations, and some of the patients, I think, felt that was because maybe we didn't want them coming in. I way prefer patients coming in. I'm very nervous about assessing patients over the phone. Anytime that I offer phone consultations, it's me trying to facilitate the patient's life, patients that might be less mobile or may have difficulty getting in and out. And I try to say that to them all the time, that most of the decisions I make are honestly trying to keep the patient's interests at heart. But if patients want to come into me, I prefer that. I prefer to see them. I can't put a hand on a tummy over the phone. I can't really see how somebody looks, and that's often a lot of how I assess somebody, how they're walking up to the door. Do they look like they have energy? Do they look like they're struggling? And a phone call assessment makes that very difficult. So I just wanted to mention that as well. I don't know if that's the case all over the country, but certainly for me, there are patients that I've specifically called in because I'm like, I feel like I don't have a grasp on this patient because I can't even picture their face. And they're kind of like, why are you calling me in? And I'm like, because I need to know how you're doing, and you can't assess that over the phone. So that's another thing, is quite often your perception of maybe the doctor not wanting to see you, or not wanting to give you time, that might be, you might be perceiving it incorrectly. Maybe the doctor actually is trying to make your life easier and trying to move things along more quickly and smoothly for you. And actually, if you just say, actually, I'd love to see you at next visit, that will be facilitated.
Right. You want to hand it in or speak? Okay, great. So while that's coming, there's a question here about a patient who was diagnosed with ET in 2020 and takes hydroxy and aspirin and has recently developed psoriasis. Is there a connection between the disease or the medication and psoriasis? And maybe we could just cover skin issues with hydroxy in the answer. Anyone want to answer that one? Mary Frances?
So, psoriasis is much more common than myeloproliferative neoplasms. I've never seen that association. That doesn't mean to say it hasn't happened, but it's probably more likely psoriasis can develop at any stage in life that it may well be just incidental. But hydroxycarbamide is an issue with skin disorders. There's clearly now increased skin malignancies in people long-term on hydroxycarbamide. That's a difficulty. We all live with this nice white skin, which we're horribly exposed to the sun when we were children, at least. I remember being thrown out in that beach out there with, nothing. So there's a whole lot of issue around there. But I think we certainly feel over the last few years we've tried much harder to tell people on hydroxycarbamide to keep out of the sun and to try and protect their skin. But that may be, it may be too late. So anybody on hydroxycarbamide should watch their skin, as we all have to do anyway, and see if there's anything. In an ideal world, I would love to have a dermatology clinic where I could get all the people on hydroxycarbamide and ruxolitinib probably as well to get seen and get their skin looked at once a year or something like that. I haven't got that service yet and I don't actually see it, so we're back to relying on looking yourself and getting referred.
Okay. I've been on hydroxycarbamide for 28 years plus and have had various skin lesions. And what's changed is I will not go out in the sun without a hat on. And you've got some quite inexpensive, fun hats you can wear. But also, in the old days, Factor 50 used to make you look like the abominable snowman because it was a white face. But now you can get this little thing, and it's Factor 75, and it really doesn't show at all. So you're not walking around looking like a snowman. But I do agree with you, Mary Frances. I have to go to see a dermatologist. And I think for my case, it's probably I've been on the drug for very, very many years. But I do implore everybody to just keep out of the sun. In the old days, we were told we were looking pasty-faced if we were too white. But actually, it's quite good to look pasty-faced these days.
In my practice, if there's anything at all, if I refer them to the dermatologists, they will get seen very, very quickly. But there isn't a service to get everybody screened.
Everyone in the audience.
Next time.
If anybody wants to know what they are, come and see me afterwards, and I'll tell you.
Also, the case for ruxolitinib, as Mary Frances mentioned, there is an increased risk of skin cancer with that drug. So don't just think it's only hydroxy, also case for ruxolitinib. There's a question here from Patricia. who says she has burning feet every night. Can this lead to permanent damage, and could this be related to her MPN? Janusz?
Thank you. That's a very specific question. Burning feet is a pretty frequently reported symptom of patients, so it's very hard to give a very specific advice. But what I would recommend is actually to talk to your doctor when at your next appointment. Someone needs to have a look at your feet. Usually those things don't lead to the permanent damage, but obviously can be very symptomatic and can affect patients in a very negative way long term. So maybe there is a role for local treatment, maybe there is a role for investigation towards neuropathy, nerve endings damage. That needs to be looked at kind of comprehensively in the context of your diagnosis, your treatment that you are receiving. So the best advice I can give you, talk to your team at the next appointment.
Sorry, I asked that question. I've been through everything. I've been through neurologists. I've had this, like, even before I was diagnosed. It was my first, I suppose, introduction to PV. And I've been through vascular and neurology, everything, and nobody can come up with anything. So I know it is one of the symptoms that you see on MPN Voices, burning feet and hand sensation. And my concern is, you know, am I doing long-term damage? Because I have it every night. And it's only at night I really suffer from it. That's all.
So maybe you may consider talking about this in more details at the breakout session, you know, because that's very, very specific clinical context that you are presenting.
I just wondered if anybody else had similar symptoms, really, if you have come across it. Thanks.
There is a thing called erythromelalgia, which is described sometimes. It's another funny medical term, but it effectively can mean redness and burning of the hands and feet. Usually it's really sensitive to aspirin. I'm sure that's been looked at, and we're kind of straying into giving an opinion here without all of the medical information. But just to use the opportunity to describe, that is what erythromelalgia means. Melalgia means sort of pain, and erythro means redness. Are there any other questions or comments from the audience? Great.
Just a general question, I suppose. Post-ET MF, would that be worse than MF been diagnosed on its own? Or is the post-ET part putting you in a higher risk for every... And then the levels, the grades that are MF from grade 1 to 4, how are they graded?
Right, so I will answer the first part of that question, then I might pass the microphone to Claire, who's going to speak about myelofibrosis. So, in general, myelofibrosis, whether you get there from having ET or PV or whether you begin with that condition, it's not really any different in terms of its severity. But we do use slightly different scores. So Claire might want to talk about that, but and also about the point about grading.
So exactly as Claire said, we use different scores. So we won't just take in your blood counts, but I don't know if people have had a thing called next generation sequencing where we look at all your mutational profile, and that in combination with your symptoms, in combination with your blood counts, we put that into a score. And at that stage, we can, what we say, prognosticate. In terms of the grading of the fibrosis, there is a condition called pre-fibrotic myelofibrosis, and then there's, primary myelofibrosis, or in your case, secondary myelofibrosis. With pre-fibrotic myelofibrosis, when we look at the bone marrow, we actually see signs of myelofibrosis, but we don't actually see the scarring. Okay, and sometimes it's difficult to know the difference between an ET and a pre-fibrotic myelofibrosis. But in that situation, the fibrosis, that scoring is 1, okay? And anything over 2 is considered myelofibrosis. So that's one of the main differences. Okay.
Yes. I'm not asking a question.
Sorry. Yeah, I just wanted to know, it's sort of related to that, I suppose, but the JAK2 thing, say if you're diagnosed first and you're told you don't, like you're triple negative, and then your bloods are done again, and then the JAK turns up, you know, you were saying earlier something about, I'm not very scientific, so, but that there's lower levels of Jack and there's higher levels of Jack. So even though, like, say, if you have all the symptoms, but you're told the Jack isn't there, and then the Jack suddenly appears, can that happen? Or can it change and go up and down, or what?
We're all nodding. So basically, this is a bit about laboratory tests and what we call positive and what we call negative. So you can have features of the disease with a very low level of a JAK mutation, maybe 1%. But sometimes in the past, we wouldn't have called the test positive until that level went over 5%. So it's quite possible that the level might have been well below 5% in the past, and then gradually it's built up. Or maybe the particular laboratory is using a more sensitive test. But the medical teams that are looking after you, and the nursing teams as well, they will be well aware of those issues. And it's exactly this kind of thing about test results going up and down, which is one of the reasons we haven't started to routinely test the level all the time for patients, because it can bob up and down a bit. I don't know if anyone else wants to comment on that. It's a great question. I've certainly, we've all probably had patients like yourself who have been negative and we're all suspicious, and then we repeat it and it's come back as positive. So we've all had several patients like that.
And it's probably not that they were negative as such, it was below the threshold of detection. So we'll get a result, and the result will say that the level of detection is 5%, for example. So we'll get a negative result, but actually by a different method or with an increased sensitivity, sometimes people will have a much smaller percentage of abnormal JAK, but it is manifesting as if it was higher. And I've seen that recently. I'm sure you've seen it as well. I had a patient recently with a MIPL who's been a triple negative for a long time, and I sent next generation sequencing on her just because I was, I just wanted to be certain I'd done everything. And she came back with a tiny MIPL clone, and you might remember from earlier I mentioned MIPL is already a very rare mutation, and then she had it in such a small amount, but it's enough in her case to actually, she's had high platelets for over a decade. So it is interesting. We probably don't know everything about it yet. We certainly don't know everything about it yet. Why some people can have such a small amount of abnormal gene and protein, and it be amount to a disease that's equivalent to somebody who, let's say, is 50% abnormal JAK. It's interesting, but definitely we've all seen that.
Last year I was diagnosed with ET, and I'm at a higher risk patient. But I just wonder, how often is the JAK2 checked? Or is it?
Right, I can tell you, in Guy's Hospital, we check it at diagnosis, and we do not routinely repeat that test over time, unless something changes about the patient's disease, when we might do a test that then looks at 30 different genes to look at the JAK2 and other mutations. But maybe Aisling, you might want to comment on that, having made a comment just now.
So I suppose, just wondering, if this is, are you talking about if you're JAK negative at the start? Oh, if somebody's JAK positive at the start, I don't retest it, because at the moment we don't do anything different with it. I think there probably will come a time that we follow what we called the VAF, or the variant allele frequency, which is the percentage of abnormal JAK compared with normal JAK. At the moment, that doesn't alter what we do whatsoever, and actually, where we do the testing, I don't routinely even get the diagnostic percentage. Like I said, they report it out as positive over 5%, negative under 5%, and they don't tell me how much over the 5% it was. But like I say, I think there probably will come a time as we move on with treatments, and it probably has been done in some places just for research purposes, to see, do some treatments reduce that percentage. At the moment, that's academic. That doesn't change what we do for the patient. So yeah, my answer is I don't repeat it.
I suppose that there might be one time that we repeat it, and that might be post a bone marrow transplant. So that would be a time that we would repeat it. But on the whole, in Ireland at the moment, we get this binary report. But with this next generation, we are getting percentage. And the problem is, the reason that we're not doing is because different labs have different techniques. So it's not validated across different labs. So that's why it's still in the research zone. But certainly, hopefully, as the years go on and we get much more validation of that JAK, we'll be able to use it. And I suppose it'll be, to make sure that we know how to use it as well. But it's a work in progress.
It would be wrong to change treatment that's working really well just because the JAK2 went from 10 to 15 or 16%.
Is there one more question between now and lunch? Yes? Maybe we can give you the chance to speak if that's okay. Okay, lady at the back. Yep.
Thank you. We're just coming back to the previous question about transformation from ET to MF. Does that risk, and I suppose I know from Aisling's, it increased slightly the longer you had the condition, but is that something that, as somebody I was diagnosed quite young enough, is that something that the bone marrow eventually gets more fibrosed the longer you have something like that? Is that?
I'll have a go at that one. So if you have this condition for 40 years versus 20 years, because the increase in fibrosis is something that happens over time, there is more chance, because you've had more blocks of 10 years, if you like, but it still is by no means inevitable, and most patients who've had the condition for 40 years would not develop fibrosis. Does that help? Okay, maybe. And maybe we can fit one more question in then. Yep.
How do you best identify the window where you're going to get the best results, say, and you advise someone to go for the bone marrow transplant?
That's the longest question. It's the shortest question, but the longest answer. So I'll give it a bash, and then I'll ask if somebody else also wants to give it a bash. What I would say to my patients is, this depends on severity of disease, fitness of the patient, and whether we've got a good donor. That could be a family member or a volunteer. And so all of those factors are taken into account. So if the patient in front of me has got aggressive enough disease that I want to think about transplants, that's usually someone who's got an average life expectancy then of around 5 years, broadly. And if they're fit and they've got a good donor, I generally want them to go to transplant at that point. But it's a difficult thing for a patient because it's risky to have a transplant. And maybe this will come out in the group talking about myelofibrosis this afternoon. But sometimes if the patient is less fit or the donor is less good, or there are reasons that the patient doesn't want to have a transplant right now, there's something big happening in the family, or there are other issues, then we would sometimes wait. But usually the time is when the patient is at their best response to current therapy and is fit. I don't know whether anybody else wants to comment on that. Is there anyone in the room who's had a transplant, by the way? No. Sometimes there are, yeah. Mary Frances wants to comment, and then we'll stop.
So I think this is one of the most difficult questions we, plus the patient, have to face in the clinic. And the other bit, it says the goalposts keep moving. So I've been doing this for a very long time, and when I started, you didn't transplant anybody over 60, and I'm well over 60 now as well. Whereas now you're looking at more and more patients, and some people you treat their myelofibrosis and they get so much better that it then becomes, should they have gone for the curative transplant? So it's very difficult. It's all the factors at the beginning, and it's a moving field as they go, as a patient progresses with their disease.
Happy to chat more about that informally later. Nona, over to you.
Thank you, and thank you all for giving your time and answering all the questions. And in the groups, after lunch, well, not after lunch, the final part of the day, you will be able to continue asking these questions. Welcome back, everybody. I hope you all enjoyed your lunch. We are very lucky now to have Dr. Janusz Krawczyk, who is going to talk to us about clinical trials. Thank you.
Thank you very much. Thank you very much. It's a massive pleasure to talk to you, all of you, patients and family members, and I'm delighted to see a lot of familiar faces in this forum, so thank you for coming. And today I'm going to talk to you about what is important from the patient, I believe from the patient perspective, to understand about clinical trials and how you possibly may contribute in the future, and what could be, how can you benefit from actually participating in clinical trials. And maybe we could start with the show of hands. If there is a clinical trial for your particular condition tomorrow in the center that you are attending routinely, how many of you would like to participate? Okay, right. So I hope to improve on this show of hands. So, okay. So what is clinical trials? So let's start from the very basic discussion. You know, so clinical trial is a form of research that involves humans, that involves people. Because how do we know that a treatment, a medication, a intervention works? We need to test it. We need to test it on patients, and we need to test it on humans. And this is described as a final step in the development of medications and interventions, because first of all, you need to do your lab research, then you need to test it in animals, and then you finally test it in humans. And based on that, you can improve the treatment, you can improve the outcomes of the patients, and you can bring the new treatments to each particular disease. So why it is important? Because this is the way to develop new treatments and new interventions. And this is crucial in advancement of medical knowledge, and it is very important for the improvement of patient outcomes and patient care. There are a few terms that I always discuss with patients to make sure that they understand better about what participation in clinical trial means, and to make sure that they understand what we are talking about. So one of the very common terms used in the clinical trials is randomization. So patients are asking, okay, am I going to get the treatment? What am I going to get? So randomization is a process of tossing the coin and allocating patients to the group that gets a treatment, that gets treatment that includes a new medication, the new treatment, or the standard of care or the routine treatment. So that's what is randomization. Another important term in the management of clinical trials is blinding. Blinding means that someone doesn't know what patient is getting. So it could be single-blinded treatments, so meaning that the patient don't know what they are receiving. So they are getting a box of tablets without the name, so they don't know what they get. However, double-blinded trials are the trials that neither patient knows what they got, neither medical or healthcare professionals know what they got. So those are double-blinded trials. So single-blinded, patient doesn't know. Double-blinded, patient and medical doctors doesn't know. And the reason behind blinding is that, especially in chronic disorders, it's sometimes very difficult to distinguish between the reaction to the treatment and the natural cause of disease, between the placebo effect. So it is very important to try objectively assess the outcomes and the outcomes of the treatment. So I mentioned placebo. Placebo is a pill or injection that is used in the clinical trials that is believed to have no therapeutic effect. So it's like a sugar pill that should not have any therapeutic effect. But it is very important to include this in the clinical trials to make sure that patients don't over-report the improvement that is not there, or at the same time, medical teams that they don't over-report what it's not there. So another important term is a control arm in the clinical trial. So control arms are the patients who are treated with the standard of care. So those are the patients who are not getting the new treatment, and they're very important to be included in the clinical trials. And the last thing that I want to mention is informed consent. So every patient who decides to participate in the clinical trial need to be made sure that they understand what exactly participation means, that they understand the purpose, the procedures, the risk and benefits of the clinical trial. So the process is very formalized, and for each patient, before patient is recruited to the clinical trial, they need to go through this formal process. It is also important, I believe, to understand that the process on the conduct of clinical trials is very highly regulated in each country. So there is a number of institutions that do oversee the conduct of clinical trials, and at the government level in Ireland, the clinical trials are overseen and approved by the Health Product Regulatory Authority, HPRA. So let's say that I, as an investigator, would like to open the clinical trial in Galway. I need to get the government, the HPRA approval before I do it. So they do review the protocol of the trial from the safety and efficacy perspective. The second important institution that gives a go-ahead for the clinical trial is the National Ethics Committee, NREC in Ireland. So NREC reviews the protocols, reviews the application for the conduct of clinical trial, and they do focus on the protection of patients' rights, patient safety, and patients' well-being. So those are the two key institutions that can, and they are responsible for approval of clinical trials. All the clinical trials are required to be conducted in the compliance with the EU regulation, EU law, and with the standards of good clinical practice. So, I hope that the message that I'm sending now is that you understand that this is a highly regulated process that keeps in mind the safety and well-being of the patients in the center. So another thing that we always discuss are different stages of different phases of clinical trials, and they are numbered from 1 to 4, and phase 1 clinical trials is being the very early stage of the development of a medication or intervention, and stage 4 is a very late phase when it's used in the hundreds of thousands of patients. So phase 1 clinical trial usually involves a very small group of patients, and this does focus on the safety of the intervention. And in phase 1 trials, frequently the drugs are used only for the first time in human beings, and frequently only up to 9 or 10 patients are being involved in those trials. So those trials are conducted to look into the safety. So if there is any concern about the safety of the intervention, safety of the medication, this medication does not go to any further. Phase 2, a clinical trial includes more patients, 20, 40, 60 sometimes, and this phase is looking more into finding if the treatment is effective. So we know from the phase 1 that it's safe, and in the phase 2 we are looking to find out if there is any suggestion, if there is any formal evidence of efficacy. And obviously during the phase 2 we collect the data on the safety. And then the stage 3, which is almost, which is the final stage before the approval, before the medication, the intervention can be approved for the use, is stage 3, when it looks at the very significantly higher numbers of patients, let's say 100, 200,000 sometimes of patients. And phase 3 is looking to find out if this new treatment is better than the standard of care. So in the phase 3 trials, patients are randomized, meaning that they are randomly allocated to different treatment arms, and there is a control group, which is a standard, which is the way that how we used to treat the patient, and there is an interventional arm, which is a new group that we are looking to find out if the treatment is better than the previous one. So phase 3 compares standard of treatment and new treatment, and based on that, the phase 3 trial can be the basis for submission for the approval of new treatment in a particular disease. And phase 4 trials are the trials that are conducted after the approval of the new treatment, and they collect information from a lot of patients in the approved use for a very long time. So just to make sure that there is no safety signals, there is no safety concerns that were not seen before. So I already mentioned a little bit about informed consent. So informed consent is an initial stage of discussion about trial with the patient and family members. And the informed consent, as I mentioned, should include discussion about the purpose, duration, required procedures, key contacts for the conduct of clinical trial. And this phase allows us to make sure that patient and family members, they understand what actually it means to when we are talking about participation in this particular clinical trial. So what would be the key benefits for patients for the participation in clinical trial? So they can have earlier access to new treatments that otherwise are not available. So, and also there is ethical component, and participation in clinical trials will allow them to contribute to development of medical knowledge, to better understanding of their conditions. What are the risks? Obviously, there are the risks. So there is always a risk of coming from the side effects of new treatments. Sometimes they are unknown side effects. There is a risk of having the treatment not being effective or efficient. And obviously the need to dedicate time and dedicate energy for the participation. So I want to say that choosing to participate is a personal decision of the patient and family members, and should take into account the potential risk and benefits. So it is also important to say that patient rights in the clinical trials are protected, and patients will always have the right to withdraw at any point, and will have the right to know what is the outcome of clinical trial, and the confidentiality of patients will be always protected. And more information about clinical trials you will find mainly from your medical team, who knows what is available locally, who knows what's coming locally, but also there are in Ireland, Cancer Trials Ireland website that lists all the available trials, and Irish Cancer Society. So I hope I made it in time, and if there is any question, I'll be very happy to answer. Perfect. So the last thing, can I see if I convinced anyone to inquire about clinical trials? Are there any more hands up? Not that many. Okay, few. That's good. Thank you.
Lovely. Thank you very much. Well, hopefully some more hands might go up, because as I said earlier on, you know, research and clinical trials are vital to the progress of finding better treatments for MPN patients. Now, I'm delighted to welcome Claire Andrews, who is, sorry, I'll just make a, okay, who's going to talk to us about myelofibrosis.
Thank you. Good afternoon, everybody. So I'm sure after lunch we're all feeling a little bit drowsy, and the room's very warm, so hopefully I won't send you all to sleep. So I'm only a newly appointed consultant over the last 2 years, so MPN Voice has been so helpful for me to be able to advise my patients. So thank you to MPN Voice, and indeed thank you to to everybody coming here as well. So today I'm going to be talking about myelofibrosis. So really I'm going to do this little overview slide. So what is myelofibrosis? How do we diagnose it? How do we prognosticate, which is a big long word for how do we predict how patients do? And how do we treat myelofibrosis? So what is myelofibrosis? Thankfully, my colleague Dr. Sinead did a lot of the background work about what exactly MPN is, so I'm not going to go over that. So myeloproliferative neoplasm, as we know, is we produced too much cells, and that's because of an uncontrolled JAK-STAT activation. So if we look at that stem cell, that's the multipotent stem cell, and then it goes down to the myeloid progenitor. That's where all the problems arise, okay? So we get a mutation there, and that causes MPN. So what's the difference between MPN? Why do, for example, you can have ET and be JAK positive, you can have PV and you can be JAK positive, or you can have myelofibrosis? Myelofibrosis is a little bit different because although initially you produce all these cells, this cell here, the megakaryocyte, which produces the platelet, that cell there is the problem. That cell, when it has a mutation, produces fibrosis and scarring. And that is the main issue with myelofibrosis. So then the bone marrow becomes scarred and you're unable to make as much blood. So whereas with the myeloproliferative neoplasms, the ETs, the PVs, you have high platelets, high hemoglobin. Now with MF, you sometimes can still have high platelets, but you're more likely to have lower counts because your bone marrow is no longer working. Because your bone marrow is no longer working, what happens then is the body compensates. The body's clever. So what it does is it'll produce, the body compensates producing blood in other organs, so your spleen and your liver. And that's why patients with myelofibrosis have big spleens. So although there are quite a lot of similar symptoms with myelofibrosis and MPN, they are distinct symptoms. So I don't know if you'll be able to see this, but this is a normal bone marrow, okay? And you can see those white dots on the top, and they're just fat spaces, okay? And what you can see is these individual dots, and they're all the cells. And they're all just sitting there, you're just not doing a huge amount of damage. There's a normal bone marrow. And then we go down to here, and we can see myelofibrosis. And what you can see is just disorganization. You know, it's just swirling. Here is with reticulin fiber, and this here, this is the real fibrosis that we have. And if somebody asked me about reticulin, so this person would have a high reticulin, and that's what we're looking at. So this is, you can see then from that bone marrow why somebody wouldn't be producing as much blood because of the disorganization in the bone marrow. So there are different types of myelofibrosis. I think this has been touched on before. There's the primary myelofibrosis where you just get it, there's no preceding symptoms. And then it's a secondary myelofibrosis. You may have had ET for a long time, you may have had PV for a long time, and then you go for your count check and your doctor says, well, it's funny, actually your hemoglobin has dropped, or your platelets are dropped, we're going to repeat your marrow. So with ET, with PV, there's more chance of going to myelofibrosis than there is with ET, but thankfully it is a smaller number. I talked a little bit about prefibrotic myelofibrosis, and that's when you have changes to your bone marrow, but you don't have any of the bone marrow scarring. Does anybody have prefibrotic myelofibrosis here? It is something actually, so we use what we call the World Health Organization as our form of classification, and that's how we classify blood cancers. So this prefibrotic myelofibrosis is only a new diagnosis since 2016, so it is a rare subtype of a rare disorder. So just in terms of numbers in myelofibrosis, so probably 1 to 2 per 100,000, so it is considered rare. Usually presents at middle age or older adults. Average age is about 67. So about 5% of people present before the age of 40 and 17% before the age of 50. And there's an equal number of men and women. Some places say that there's more men involved. So how do we diagnose myelofibrosis? So the first thing is the patients, okay, so the symptoms. So what are the symptoms? And I think I touched on them a little bit. So because the bone marrow is no longer working anymore, we have impaired blood cell production. So we have anemia or low hemoglobin, we have low platelets and low white cell count. So because of that, for the anemia, you're going to be short of breath, you're going to be tired. With the low platelets, you might have increased bleeding, and low white cell count, then you might have problems with infection. Similarly, I think has been touched on before, we have enlarged liver, enlarged spleen. Because of that, you know, when we eat our dinner, we get full quickly. We call that early satiety. We've bloating. And then what we have is these constitutional symptoms, and these are sort of with all MPNs. And this is fatigue, this is the night sweats, temperatures, weight loss, and weight loss is something specific in myelofibrosis that we see quite a lot. Bone pain, the itch, clotting and bleeding. So the constitutional symptoms there are not particularly specific for myelofibrosis. They're across all the myeloproliferative neoplasms, whereas that low counts and large spleen and liver is probably more common in myelofibrosis. So when we see that you have these symptoms and we know we have a patient has myelofibrosis, I think Sarah showed already this. This is your MPN score, okay? And this is we can rate your symptoms out of 10, okay? And we can give this to you in the clinic, or you can use it. And this is particularly helpful, I suppose, before you start treatment and after you start treatment. And doctors love numbers. And sometimes, you know, we can look at this, but actually, most importantly is we need to hear your story. So as much as we can use this, we use this with also listening to your stories, because we can't really put a symptom down to a number. It's part of what we use, but fundamentally, we understand that myelofibrosis, there's so many other symptoms. So it's not so straightforward as looking at a number. So then how do we diagnose myelofibrosis? Well, we use what we call an integrated diagnosis. We use several, we don't just have one thing, we use several techniques. So first of all, the full blood count, okay? And as I said, usually the blood counts are low, okay? Second of all, we use what we call the genetic testing. I'll describe this a little bit later, and Aisling already discussed a little bit. So your JAK2, V6 and 7F, your MIPL, your CALOR, all of those. And then in combination with the bone marrow biopsy, whoever has myelofibrosis, because of that scarring, actually a bone marrow can be a little bit difficult because of all that scarring. It's actually hard to get that first part of a bone marrow. So whoever has myelofibrosis, they might be familiar with that. But we can get it with the biopsy. And then imaging is important as well to assess about big spleen, big liver, and also to be able to look at your baseline. And so, for example, I think Professor Harrison showed there that lovely picture of somebody who had a very large spleen, and then after ruxolitinib, the spleen went down. So that's, you know, it can be very helpful in that regard. So as I said already, in terms of those genetic mutations, so we have what we call driver mutations. So what is a driver mutation? This is what drives how the myelofibrosis looks, or indeed any of the myeloproliferative neoplasms, okay? So with myelofibrosis, JAK has about 50 to 60%, CALOR is about 25%, MIPL has about 10%, and about 10 to 15% will be considered triple negative. In the last few years, we're using next generation sequencing, and we talked a little bit about this. This is looking at mutations that are associated with myeloid disorders. So in this panel that I'm using here, this is just started in James's in the last few years. Before that, we were always using England, but we're now actually doing this test in Ireland, and there's about 40 mutations. What does next generation do for you if you have myelofibrosis? So, for example, if you have triple negative disease, it might show us a clonal mutation, so it helps with the diagnosis. I'll show you now in the next slide, it helps with the prognosis, or it can help us predict what your disease is going to be. Unfortunately, we're not quite yet at the targeted therapy. Ideally, like for example, in oncology and cancer, they can do a mutational panel and they can decide the treatment. We're not quite there with myelofibrosis, but I'm really hoping in the next few years with further research we can get that. So that's really, so all of that together brings this integrated diagnosis and the WHO classification of myelofibrosis. So how do we prognosticate, or how do we predict how patients do? And this is a very busy slide, and I sort of want you to half ignore it. But these are all these different scoring systems. And we use, as doctors, we use this scoring system depending on the genetic information that we have, okay? So if, for example, you have that next generation sequencing, we can use the MIPS is probably one that I would use. And this categorizes your myelofibrosis into risk, okay? So you've got low, intermediate, and high risk. And obviously, the patients who have high risk would have a less of an overall survival, and people with low risk disease have a longer overall survival. But once again, this is very much a prediction. You know, I'm always saying to patients, these are, you know, and always take these numbers lightly, you know. I was telling the story earlier on of I had a patient who had a different type of blood cancer, He had a condition called multiple myeloma, and he came into me and he said, you know, the doctor told me that I had 6 years. And he sort of looked at us, he said, like, that's 6 years. I think he thought somehow it was all, he was going to drop dead in the spot. But so all it is a prediction, okay? And what it does is it helps us as doctors to give you the right treatment at the right time as much as we can. So how do we treat myelofibrosis? So we've got the diagnosis, we've got the prognosis, and now we're all happy with where we are, so we decide what sort of treatment. So for low-risk disease, okay, so for patients who have, we've done our calculator and they have low-risk disease, actually for a lot of those patients we can watch and wait. And that's, I think, really difficult to tell a patient, so you've got this diagnosis, it's a blood cancer, it's probably going to have effect on your quality of your life, but we're doing nothing. So I do think it is difficult for patients to really to get that into their head. The next question, I think somebody asked this in the audience about, am I eligible for a stem cell transplant? And certainly this is a question that we all struggle with within haematology and certainly within myelofibrosis. So there are certain people that it can be easier. So if you're a younger person and you have what we call high-risk disease and you don't have many comorbidities, that patient, that's an easy patient to decide whether they go for transplant, if that's what they want. And fundamentally, the reason we always ask about transplant, because unfortunately transplant is the only cure for myelofibrosis at the moment. So these are all the factors that we have to take into account every time we go for transplant. So for those high-risk young patients, certainly that's, but the question, so for those, this is our European bone marrow transplant expert consensus. So for all patients who are intermediate 2 or high-risk disease, less than 70, they're the sort of, and they don't have much comorbidities, transplant is an easy enough decision. But this is the group that's more difficult. What about the people with the less risky disease? They're less than 65, but they have other things. They require transfusion, they might have blasts or sort of leukemia cells in their blood. All of those are sort of saying to us, well, maybe, you know, we should consider transplant. So all of this is the area that we all sort of are talking about, because transplant is not straightforward. There's a lot of toxicity with it. There's a lot of complications with it. So that's why we have to choose our patients very carefully. And I think really everyone should have a conversation regarding transplant. And you can say to your doctor, you know, what about me? Can I get a bone marrow transplant? And they'll say, look, I've already spoken, I've already thought about it, but actually you're low risk. Or actually you're 80, you wouldn't be deemed for it, or actually you have significant cardiac disease, you have diabetes, you know. But I think that conversation needs to be had. And sometimes I even send patients over to James's so that they can have the conversation so James is the hospital that does it, so they can have a conversation with somebody else, and we would often do that. Okay, so we've gone through bone marrow transplant, and I think Janusz has very nicely gone through, am I eligible for a clinical trial? And, you know, we all would like all our patients, to tell you the truth, to be on a clinical trial, because it gives us access to drugs that we might necessarily have access to, and it also gives us answers. Unfortunately, in Ireland at the moment, we don't have a huge amount of clinical trials in the space for myelofibrosis. Luspatercept is one clinical trial that's open. It's open in James's and the Mater and Cork at the moment. And then Mosaic, which Mary Frances McMullen will just talk about. But that's something that we as doctors are continuing to try and get as many patients on a clinical trial as we can. So then, we've gone through bone marrow transplant, we've gone through eligibility for clinical trial. The next question is, am I symptomatic, okay? Do I have a large spleen? And some people have a large spleen, but they're actually not symptomatic from it. So that next question is, am I symptomatic? So we have several options. For example, if you're low hemoglobin, we can give you a drug called erythropoietin, and maybe patients are already on it. And that helps to bring up the red cells in about 50% of patients. Danazol is another agent that we use, and that can bring up the hemoglobin in about 30% of patients. And then immunomodulators as well can bring up the hemoglobin in about 10 to 20%. We've heard a lot about JAK inhibitors, and I'll talk about them a little bit after. For splenomegaly, hydroxyurea, I don't think it has a massive effect. Really, the JAK inhibitor is really what's excellent. Hydrea does work, but the JAK inhibitor probably would be better. Splenectomy, very rarely done, and radiation is really in the palliative setting. For constitutional symptoms then, JAK inhibitors are really fantastic. So I'll talk a little bit about JAK inhibitors. So we have 2 JAK inhibitors that are available in Ireland at the moment, ruxolitinib and fedratinib. So JAK inhibitors are available for myelofibrosis and also myelofibrosis after ET and PV. And fedratinib has only been licensed in the last year. And once again, that's for frontline myelofibrosis. At the moment, most people, if they've had ruxolitinib and the ruxolitinib has stopped working, then we go ahead and we can give them fedratinib after that. There was some very early concern in clinical trial about a neurological toxicity called Wernicke's, so most patients will be on thiamine to prevent that. So in terms of other clinical trials, and I know Professor Harrison touched on this, so in the States at the moment, pacritinib has been FDA approved. However, it isn't EMA approved. For us in Ireland to have anything approved, it has to be EMA approved first. So realistically, it probably takes about 2 or 3 years for once it gets approved in America, or even longer to get approved in Ireland. So I would imagine that maybe the momelotinib even might be probably another 2 years or something like that before it is approved in Ireland. Now, thankfully, the momelotinib can be given, it's particularly given in patients who have low hemoglobin, and there is compassionate access. So the actual drug company are giving it away for free, which is fantastic. So these are the four JAK inhibitors, and I think this is the point: is that as a patient, you want choice. I want to be able to look at you, look at your blood counts, look at your symptoms, and decide which JAK inhibitor to choose based on your symptoms as opposed to what's available to me. So ruxolitinib and fedratinib can be given in first line. Pacritinib then can be given when your platelets are low, and that's why it's specifically, that's how it's been given. And then the momelotinib can give when you have anemia. So hopefully in a few years we'll have the choice of all 4 JAK inhibitors. We'll go to Tina. Yeah, sorry. So, and the one thing as well, just about, so what the JAK inhibitors do, they can help with the large spleen, and they can help with symptoms. But this shows the long-term survival after ruxolitinib in the 2 major trials, Comfort 1 and Comfort 2, and they actually showed an improvement in overall survival. So the risk of death was reduced by 30%. Now, for people who know a lot about clinical trials, they know that this study actually wasn't specifically designed to look at overall survival, so you can always have a debate about this, and this was what we call an after the fact analysis. But anyway, just to show you that there was an improvement in overall survival with ruxolitinib and myelofibrosis, which is fantastic. And then Professor Harrison has talked a little bit about that, but the future, these are all the agents that are being worked at the moment in these phase 1, phase 2, phase 3 trials. So there's a lot going on in myeloproliferative neoplasm. There's a lot going on in myelofibrosis. And there's a lot of people working very hard to ensure that patients' quality of life and overall survival is improved. And really what we're looking for is that disease-modifying agent. What happens with myelofibrosis is we cure, and we want to get that agent that can do that for myelofibrosis without the toxicity of the transplant. So thank you very much, and I'll be talking at the breakout sessions for anybody who wants to.
I think you'll all agree that was also I'm looking at the smiling faces, a very useful talk. Thank you so much, Claire. Now it gives me great pleasure to welcome a patient speaker, Sinead. Dolan, can you write this up? Sinead is very kindly going to talk to us about her ET journey. Welcome, Sinead.
Thanks, Nona, and good afternoon to everybody. My name is Sinead Dolan. I am a patient in I'll call it the regional hospital, because I still call it the regional hospital here in Galway. And my journey to my ET diagnosis was both a very long journey and a very short one. The long journey was I had my GP had noticed I had high platelet counts. She'd noticed it over a couple of years. It wasn't going down, so she asked me if I would be happy for her to forward my details into the haematology department here in UCHG, and I said, go ahead, what harm will it do? And I spent a couple of years in and out, going from room to room. I begged to see, could I see a haematologist privately? I've got VHI coming out the wazoo. I mean, I could pay for this. I didn't have time, work time to spend, moving through the hospital. And every time they did a blood test or some kind of a test, everything came back negative, and I thought, this is a complete waste of time. I'm just not going to bother anymore. So I had an appointment it was January 2020, and I got the text from the hospital in December, like, are you going to attend? And I just went, no. Enough is enough. I don't have time for this stuff. So unfortunately, just before Christmas 2019, I started to get what I thought were hot flushes. So I thought, okay, it's an age thing. I passed a certain milestone age, and I thought, okay, it's starting. I'm menopausal. And I went from like 0 to 1 million overnight. And it was kind of a little bit scary. And I thought, okay, look, Christmas is coming. I'll wait till after Christmas. I'll go to my GP. We'll discuss HRT, and this will go away. And that's always my way of doing things. This will go away. It'll be grand. So unfortunately, over that Christmas, my mother passed away, and the flashes got worse, and I developed this cough. And this was just before COVID, and a lot of people were coming to her funeral. It was a huge funeral. A lot of people were sick, and as we know now, it was probably COVID starting in the community. So I put it down to flu. And when I came back to Galway, went to my GP, got some antibiotics, everything was fine, went back to work. And this is where it went from a very long, over years, in and out, to very fast. Over 4 days, I went from being a relatively healthy person to literally crawling around my house because I could not stand, I could not breathe, I could not move. And I kind of thought, okay, there's something wrong here. I rang my dad and I said, could you come and bring me into the Galway clinic, because I don't want to waste people's time in the regional because they're busy, they've got sick people. I think I just need to be rehydrated, because I had Googled symptoms of grief and I thought, this is what it is. I think I just need to be rehydrated, get an IV, go home. So he brought me to the clinic. He had to get a wheelchair to wheel me in, which I just felt so bad about. And we went into the emergency department. They took one look at me and rang an ambulance. So when the hospital is ringing an ambulance, you kind of go, okay, there's something wrong here. And the attending consultant said, we think you've got a clot. And I'm like, oh, okay, grand. So ambulance came, whisked me over the bridge into A&E, straight through, which I was quite impressed about, because all you hear about queues and people, and straight in. And a very nice consultant was there, and they were all crowded around me, and I was like going, can I go home? Can you just give me something, I can go home? And they were like going, I said, do I have to stay tonight? And the doctor said, well, I think you might be here for a while. So, and I had 2 friends came in with me, and God help them, because the doctor started giving out to them, like, why did she leave it so long? Why did you leave? And they were like, oh, she was fine last week, she had a hot flush, that was it. So it turned out that I had 2 very large clots, one in each lung and one in my right leg. I was brought up to ICU. I was in ICU for 2 days. I was very lucky. The respiratory consultant that was on duty was a relatively new consultant in the hospital, and he just got on the phone, rang everybody, got permissions for various drugs. Don't even ask me, because I'm really bad at knowing the names of things. I was in ICU for 2 days. They were trying to figure out what caused this, because I hadn't been away. There was no usual cause of clotting, and then I just happened to mention, oh, I go into haematology every few months, but it's just a waste of time. And Sorry, Sarah. And they went, okay. So I was brought back onto the ward. I have to say, I know people give out about our health service, but the help and support over those few days that I received in UCHG from all of the consultants, all of the nurses, all of the staff was just amazing. And when you are sick, they really bounce into action. So eventually Dr. Nunes arrived at my bedside and going, hi, Sinead, and I was going, hello. And she said, we're going to have to do a bone marrow. And I was like, oh, God. Do we really? Yeah, I think we do. We've ruled out everything. We think we know what this is, but we need to get, a final diagnosis and verification. So I was petrified about the bone marrow. But I will say to anybody, it's actually not that bad. It's the thought more than the action. And once it was done, I took 2 paracetamol and I was fine. So she came back to me and said, yes, you have a really long word. And I go, huh? So she wrote it down for me. So now I know I have triple non-essential thrombocythemia. So I didn't start the medication until probably end of February, beginning of March, because the clots had been so big. I was getting the daily injections to reduce the clots, so that was fun. And then once they were kind of happy that everything was stabilized, I went back in and they put me on Hydrea to start with. That was February 2020, and then we all know what happened in March. And I had to go in and out of the hospital during COVID for blood tests and checking and see how things were going. The Hydrea did not suit me at all. I'm lucky I have very thick hair, but I started losing my hair in bunches, and I found that probably after everything I'd been through, the most upsetting thing was my hair loss. And it was really just at the front. So Dr. Nunes kept encouraging me, like, your body has to get used to this, it's going to take time, blah, blah, blah. And I was like, okay. So I stuck at it for 3 months, and then I just thought, I can't do this anymore. And I was due back in to her in June 2020, and I just said to her, I'm not taking it anymore. And she was like, oh, well, you had such an event and blah, blah, blah. I was like, I think what I said to her, which is probably not great, I said, I'd rather be dead than bald. So, but it was just a personal thing to me. So she then said, okay, let's try something else. So at that stage, they put me on Zagrid, which is, and I think if I pronounce this correctly, Analgrid, is that right? Something like that. And I take 10 milligrams a day. I've been doing that, so that's just 3 years now. And I have to say, I haven't looked back. I've had no symptoms. I'm sitting here today, I feel a little bit of a fraud when I hear people talking about the tiredness and the itch and the burning and the night sweats. I don't have any of that. I've been very, very lucky. I train, I go a personal trainer 2 hours a week, I go spinning for a class a week. I have abundance of energy, I travel a lot with work, I have a lot of things going on, so I've been very, very lucky. My life has not been impacted too much by my diagnosis, and I really hope that that's going to continue. So I would say to anybody that's worried or anxious, it's something that you can live with. It hasn't impacted, and I don't want to preach because I know there are people that are suffering, but luckily it has not impacted my life. I'm living my life normally. And I know that Aisling was not impressed by the phone, over the phone consultations. I love that. I can schedule it in between calls, it's great. So, and I'm sure Dr. Nunes probably would like to see me more often, but it's from me and where I am in my life right now, it's working for me. So that's my story. I hope it'll help some people. And if anybody has any questions or you want to talk to me, please. I'm sitting there because I was late. So thank you very much.
what an inspiring story, and again, gives hope. Thank you, Sinead. I'm delighted to welcome Professor Mary Frances McMullen from Belfast, and she's going to talk to us about what causes MPNs. Thank you, Mary Frances.
So thank you very much. So I'm Mary Frances McMullen. I'm from Belfast, Queen's University and the City Hospital in Belfast, and I've been treating MPN patients for more years now than I care to remember, perhaps. And the question always that you get is, why have I got this? What actually causes this MPN? Now, this is not the question that we've just heard alluded to in myelofibrosis. If you have a JAK2 mutation, that drives the MPN. But the question everybody asks is the one before that. Why have I got this? What caused that in the first place? So that's the question that I get asked. It is like looking for a needle in a haystack, and I am not going to be able to tell you at the end of this what causes your particular MPN. What I'm going to try and show you is how we go about looking to try and answer that question, and maybe in the future we will get more answers. So in order to look at what causes disease, the people who are involved in this are people called epidemiologists. And as you're going to hear, we've got into quite a lot of research on this, and this all started out with me linking up with an epidemiologist, my very good friend Leslie Anderson, who's now a professor in Aberdeen. And she is an epidemiologist, and what they do is look and study the incidence of diseases, but then they go further to look and see this sort of thing of what causes them. She describes herself as a disease detective, and that's quite a good analogy. And she's interested in, and this is what an epidemiologist does, how many people get sick, sick being the disease, whatever it is, who gets sick, why people get sick, which leads on to, of course, what you want to do, what could be done to prevent the people getting sick. So if you know what causes it, then you might be able to do something about it. And also what can be done to improve patient outcomes. So I give this next because I think this is the beautiful example of what an epidemiologist can actually do. And this is Dr. John Snow, who is actually considered to be the father of epidemiology. And he is the man that discovered, they all were men in those days, of course. He is the man who discovered that cholera was linked to this Broad Street well in London. And what he did was he looked at all the people who died of cholera and where they got their water from in this particular area, and was able to plot that if you got your water from the Broad Street well, you got cholera. And this is in the 19th century, you probably died of it. Whereas even if you lived round about, but you got your water from somewhere else, then those households didn't have cholera. So he was able to establish a very strong association, and I will come back to association, between the Broad Street well and getting cholera. And of course, then what people were able to go on and do as microbiology developed, discover that the Broad Street well was absolutely full of the bacteria, the cholera vibrio, that caused cholera. And if you drank the water, you got cholera. So that's what you want to do. It's a very nice, clean example of one thing, but that's what you hope to do when you're carrying out these sort of studies, and that would be the ideal. Needless to relate, of course, when you go beyond an infection like that, it gets much more complicated. So when we do this, first of all, you can very quickly get, and we've heard a lot of this today, who gets myeloproliferative diseases? Well, you can see males and females, different ages, more throughout the age groups. You get this sort of data quite quickly. We've heard all that today. That's interesting, but so what? But what we want to go is go further than that and actually look and see, people come in to me and say, I worked in such and such a place. Do you think that could have caused my MPN? Or I was exposed, I don't know. But that's the sort of question you want to look at. But how do you study this? And this is where it becomes quite complicated. So the first thing we did, which was way back about 2010, is we looked to see who has done this before. What have they found? You'd think lots of stuff would have been done before, but there's a very systematic way of doing this, which the epidemiologists are very trained in, where you search the literature. And we did do that, and we found 9,000 titles and abstracts associated with things that might be causing myeloproliferative neoplasms. But actually, when we looked at that, there were actually only 19 studies. And the whole of the world had, well, the whole of the world in the English literature and anything we could get translated into English. But that's where most of the scientific literature is. 19 studies that had looked at the things that were involved in myeloproliferative neoplasms. So we actually spent a lot of time looking at all the information that was in those. What was very interesting was 19 studies. It depends on your point of view whether you think that's quite a lot or very little. I actually think it's not that much. Many of those studies were tiny, and the numbers of cases were quite small. So actually, overall, there wasn't very much out there. But what was there? Well, there were certain things were associated with myeloproliferative neoplasms, and put some of them here. Family history, Jewish descent, autoimmune conditions, certain occupations. And that's always an issue, because in certain occupations are they exposed to things that might lead to this. And there are all sorts of databases where people have looked at this. We actually looked at it, and there was some evidence overall that commercial pressmen, poultry workers, petroleum refinery workers, funeral service workers, and electrical device workers, and cooks, waiters, clerks, hairdressers, nurses, farmers, electricians, photographers, rural sector jobs, agricultural workers. So overall, those 19 papers, these were the things that came out. There was some evidence they may be associated with MPN. Now, if you look at those occupations and you say, well, why would that be? You can come up with all sorts of theories. Very obvious ones like petroleum refinery workers, there's all sorts of chemicals there. Actually, funeral service workers work with all sorts of chemicals as well. So there's all sorts of things like that. But all that it's really telling you is that there are certain things in the literature, and that was all there was. Now, before I go a little bit further to how we looked at it further, I need to give you a little bit more about this issue. We're talking about the cause, but actually what we look for is association. So what do we mean by that? Well, if you look at people with lung cancer and what things are associated, if you look at these big groups with lung cancer, you will find, and it's well established, that alcohol is associated with people who develop lung cancer. Does that mean that drinking more alcohol causes lung cancer? Almost certainly not. But if you put the numbers in, you will find that there's an association. Because, of course, what happens if people take a lot of alcohol? They probably smoke as well. They certainly, up to recent days, hung about in smoky atmospheres. So probably what you're picking up here is the fact that the linked cause between developing lung cancer is the smoking, not the alcohol. But before you get to that, you have to look for the association. So be very, very careful and pull me up all the time, because really all we can get is associations between things. But it's very important, is it important that the funeral service workers are exposed to something that makes them more liable to develop an MPN? So the other concept I need you to get is that of who you look at for these things and what you compare it to. Because, for instance, if I want to look at, we'll pick on these poor old funeral service workers again. If I want to look and see, do they get more MPNs, I need some sort of a control group, because there'll be lots of people will have been exposed to the same thing. So we need to have a control group who don't have the MPN, and then we have to look at the differences between those who have disease X and those who've had the same exposures but don't have disease X, and see if there are any things that come out differently. So when you get to these, you have to have a control group, and then you compare the controls to the cases and look at the differences. So we looked at the literature, and we thought there definitely needs to be more work done here, and so therefore we set up the Mosaic study, the Mosaic pilot study. And what we wanted to do in this was recruit, it was actually approximately 100 patients and approximately 100 controls. We did it in Belfast and Southampton, because that's the two places where the original people were keen on this, and we had Glenn James, who was the PhD student who actually did all the work. We had to get money to do it. I'm afraid money gets mentioned in this quite a lot, and that's where MPN Voice came in, because they completely funded this and got this off the ground, and it wouldn't have happened otherwise. But what we wanted to do, it wasn't just to look at what were the causes of MPNs, but we actually wanted to look, how could you do a study and what way could you do this, and test it out to see, because there was all this stuff in the literature which was ancient in databases. We wanted to look at how could you actually get controls. You can get controls from two groups. You can ask the patient to find a control for you, they're quite motivated, or you can look at GP, various ones from the community. Which one would actually recruit the controls? We had, as I'll show you, various ways of actually assessing all this, the various questionnaires. We wanted to look at all of that. What would work? Could you do it all over the telephone? Telephones were in even in 2012. And also, could we collect samples from people? So we did that. It was actually, once we got the funding, it was actually very successful. We over-recruited, and we got a whole load of stuff that we went on and published. And I'm sorry, if you're an academic, if you have to publish it. If you don't publish, you didn't do it. So we actually did really, really well. We were able to look at the patient perspectives in the case control. We were able to look at different things, how they fitted in with the Irish blood donor population. We looked at the symptom burden, and I'll show you more of that because you'd like it. And we looked at the recruiting of controls. We looked at all different sorts of things. We looked at getting the samples. And what I will come to, it wasn't actually powered for analysis to see if it would actually tell us anything about the associations, but actually that we did so well that we actually got some results out of that. So that was the Mosaic pilot. That's all the papers we got, which is really very good for one study. But we also went on to analyse to see whether any factors in this study of 106 with 126 controls. And it did have sufficient ones to see that there were some things came out associated with myeloproliferative neoplasms compared to the controls. The thing that came out quite strongly was what's called the spare room effect. If you were brought up in a household where there was more than one child in the bedroom, you were more likely to develop a myeloproliferative disease than if there was only one child. Now, that's highly relevant in Irish families in the past. This is where the association comes in. What does that actually tell you? Is it actually socioeconomic? Is it likely to do that? You know, if there's lots of children in the bedroom, is it actually a factor? But we don't know that. That's what we got. We also found that smoking, not a big surprise, was associated with the development of JAK2 positive myeloproliferative neoplasms. In ET patients, essential thrombocythemia, it was associated with higher body mass, and the number of previous CT scans was also associated with the development of a myeloproliferative neoplasm. But that's difficult as well, because as you get a myeloproliferative neoplasm, then you're more likely to have more scans. And the radiation exposure for scans has hugely changed, gone down over the years. So these were all interesting facts, but they didn't make they didn't give you the answer and weren't likely to. What we did know by the time we'd done the study, we knew what biological specimens we could collect. We were able to show that the myeloproliferative patients had, and you like this when all they talk about fatigue, had much more symptoms than the controls. So those who we were talking earlier on about not being taken seriously. If you take a group of age-matched controls, but not with myeloproliferative neoplasm, the patients are more tired, have all more symptoms. So it's not just that you're getting old and complaining of these symptoms. There actually are more symptoms. So we published that separately and showed that. And we also knew that trying to get random controls was really, really difficult. That the only way really to get a good group of controls was to actually ask the patients, could they recruit somebody of the same age and sex but not genetically linked, who would then get controls. Now there's lots of arguments about controls and what are the best controls, but the bottom line is, how can you actually get a group of controls with your study? And that proved much better. So that's where we were, and we published that. And then we decided what we really needed. We had, by this stage, done the biggest MPN study in the world. It was much bigger than all those 19 small ones before. But it wasn't big enough to really look into what we wanted to see. So we then decided what we needed to do was a big study with lots of patients and lots of controls, and we would be able to roll everything into that. So that was the plan, to do Mosaic. We had a very long battle to get funded, because this costs money. You've got to have people to do the interviews, you've got to collect the samples and so forth and so on. And again, we were hugely helped by MPN Voice. As you will see, when we eventually got it together, then we got COVID, which put everything back. However, where are we? So we have open a UK-Ireland case-control study of classic MPNs, and you can see here the sites that are open and opening soon, and this is up to date. So there's a number of sites distributed throughout the UK, and Cork is hopefully it is open. Well, it's just opened. Just opened. So we've tried very hard to get Cork in, and we've managed that. And this is the Mosaic study. We hope to get 650 patients and 650 controls. That was what the statisticians and what we thought was feasible. They have to have a clinically confirmed diagnosis of MPN. The bit that people don't like, but it's actually the epidemiologists are very keen on, is that they've been diagnosed within the previous 24 months. In the original study, we took anybody, but the problem is that if you take them that have been diagnosed for years and years, then you get very mixed up with what happened after you got the diagnosis, and what we're really interested in is what happened before the diagnosis. So, taking advice from my epidemiology colleagues, we said, if we're going to do this, let's do it properly and really try and get a good sample. They have to be over 18, they have to be able to give informed consent, and they have to be physically and cognitively capable of completing the questionnaire. That's always there. You don't want to be asking people to do things that's not within their, it's not fair to ask them, basically. We also ask, it's not mandatory, but we do try to get each patient who's recruited, if they will give the pack to a friend or neighbour or somebody and send it in, so that we keep recruiting controls as well. And we're all over the country, both countries, and therefore the idea is that we'll get a spectrum right across, and then we'll get a spectrum of controls right across. So it won't just be the people in Southampton where we started out who live beside the oil refinery, it'll be all over. So what we're going to do in this, because I maybe haven't explained this very well, we want to evaluate, first of all, lifestyle factors, medical risk factors, and occupation. So there are people called occupational epidemiologists, and they have questionnaires which look at all these factors. So anybody who goes into this study gets sent out a questionnaire with some information about what jobs they've done in the past. That's just to speed it up. And then they get a telephone interview where they go through all of this and take them in different directions. And I wouldn't be able to do that. That's part of what the pilot was, to test all this, and there's really clear ways of doing this. They also do a quality of life And this idea, we look at the quality of life. And the idea is both the controls and the patients do both the surveys and the quality of life. And this idea that everybody likes. The red line are the patients, and the further out you are, the more symptoms you have. The blue line is the controls on the spider plot, and you can see that the patients have a lot more symptoms than the controls. So that's good information for those who can't get those around them to believe that they really have all these symptoms. We also will collect samples. Now, this is not funded within this research, but will give us an enormous bank to take us further to look at and do a lot more. You can do actually genetic epidemiology. We've talked about the JAK2 causing this, but if you could look further at the samples and see what other molecular events there were, we would have a great resource. So this is the sort of occupational history that the person doing the telephone interview goes through with the people. None of these interviews, they have to be capped at about an hour and a half, but they take about 40 minutes, and they're set up at a time where the person agrees to come and have the interview. So where are we now? Well, the study reopened in December 2021. It was actually open and then, of course, got closed by COVID. COVID has been a huge issue. There's 15 sites open in Scotland, Wales and Northern Ireland and Cork now. Total of 261 participants, and there are 4 sites opening soon. The problem with this is that it's because of COVID, it's been really slow. It got stopped. All the research centres got stopped, and then it's been a question of getting all the sites back open again. So that's just doing percentage. Belfast has over-recruited, but that's a slight cheat because we were open before COVID and had quite a lot of ours recruited already. But we're sort of struggling. And this is my more or less final slide. And this is showing you the target numbers. And the red line is how, if it had all gone nicely, it would just have gone straight up. You can see the bottom line is this, where we are. And I got this from, and where we want to be. And you can see we're up to 261. But this is what I want to do before I retire, is get this study done. Because, you know, I think we will now, we haven't got guys open yet. When we get all the sites open, we will do this. But it's ongoing struggle all the time for money, because it costs more because it's stopped, and you've got to employ people to have the interviews, and postage for all these things costs a fortune. However, we will have at the end over 5,000 samples, so when we do it, we'll then have a whole load more projects for people to do. So that is Mosaic. It's not the answer, but it's an attempt to look at this further, and I would encourage anybody who can get to participate in the study. If you haven't got a site, which obviously you haven't, I think you can go to Cork. You only need sort of sign a consent form and get somebody to take the blood sample done. Okay, so I've gone on too long for Nona, but thank you.
Wonderful.
I think I have to say, over the years, and Maz and I have done a number of forums around the UK, Northern Ireland and here, the thing that most patients want is an answer to why I have an MPN. And I can't thank the teams in Belfast and Aberdeen enough. And Professor Leslie Anderson and I had a recent conversation, and she's definitely hoping to publish some results by the end of next year, which is really exciting for all of us, for all the fundraisers too, who've raised so much money for this particular study. You know, it's been amazing. Thank you. My next speaker is, where is she? Where's she gone? Oh my God. is Nicole Murchie, and she is going to talk to us about her journey with PV. Welcome.
Hey. Hi everyone, my name is Michal. I came to Ireland from Israel, and I came here just to make everyone's life difficult pronouncing my name. And ever since then, I try to go to many places I can to make people see what I feel when I try to pronounce Irish names. I'm a nerd. I'll start by this, and that will explain a bit about my journey. I was diagnosed with MPN with PV in 2018. When the disease, what was the onset of illness is a different question. I'm going to go back to my teens. Somewhere in my teens, I had abdominal pain. I went to do ultrasound scan because my GP was concerned, and I was found to have enlarged spleen. To my parents, that wasn't a big surprise because that was always the case. Every time somebody was checking my stomach, they told them, oh yeah, she has an enlarged spleen. But because my father had a blood cancer, and apparently a few of a generation above him also had blood cancers, my GP said, you know what, maybe you should go to see the hematologist, just in case. The hematologist was very interested. I am also Jewish, so Professor McMullen, thank you very much. I now know about other risk factors that I was not aware of. So family history, Jewish, and also I was diagnosed with an immune deficiency. So thank you, 3, now I know. Associations, I appreciate that. So I was checked, and he also wanted to do bone marrow tests just because he was curious, and I think he also wanted to publish some papers. And indeed, he found some abnormalities in my bone marrow. And from there on, he suggested that what I should do, without any explanation about what that means, he suggested that he'll remove my spleen and give me chemotherapy. Preventative chemotherapy. I was about 16 or 17. I refused. I asked him politely if he would be able to return my spleen if he finds that everything is fine. He laughed at me and said, no, I can't. And I said, yes, I thought so, so you're not taking it out. But he did insist on seeing me regularly. Now, ever since then, I thought that the wise thing to do is to compile my blood tests. So I have my blood test results since I was about 17. I said I was a nerd. Everything seems to be fine. I was seeing my hematologist regularly until he was mistreating my father with cancer, and I stopped going, and I moved to a different hematology that asked me how exactly I was so rude and irresponsible to drop seeing my GP, my hematologist, when my bloods were not fine and my bone marrow was not fine. We repeated the bone marrow, and it seems to be quite stable, whatever that was. There was no quite conversations about the type of cancer, but it was very clear that I have high risk for a cancer and that I need to be seen regularly. We had conversations about whether I should donate bone marrow to myself and keep it just in case I will need it. But we had a lot of conversations. But then, you know, it does affect you knowing that you will have cancer at some point in your life. You don't quite know what. So we continue with the ongoing meeting with my hematologist. Nothing changed, apart from me being always a little bit anemic with very low hemoglobin. But whatever iron I was taking was not working. So at some point, probably in my 20s, my blood started to change. I always had very small blood cells, a lot of them as well, but my hemoglobin started to go up. No explanation, it's just changed. And again, I have the record, so I know. What exactly happened, we don't know. Then I moved to Ireland, and I was continuing to see my GP, my hematologist in Israel. I moved to the clinic here at some point, when he basically said, look, it's not, you're going to stay in Ireland, you might as well move to care here. Plus, I also needed to be seen by an immunologist for my immune deficiency. So all things a bit more complicated when you have more than one disease. So at some point, the hematology wisely said that actually there's nothing to do with me. My bloods are okay-ish, high hematocrits, a little bit high platelets, high hemoglobin, but all in order. No point in continuing to see me, and they've decided to discharge me. Upon discharge, the hematologist, the consultant, whose name I do not remember, decided that would be a good time to take a blood test for me. I didn't quite explain what for, just to make sure that I don't have a certain disease that is illness, which is absolutely sure that I do not have. And with that, I was released. A couple of years later, I happened to see my file, and there I found that my blood was checked for JAK2 mutation. Okay, it came positive, but there was no follow-up. So I've insisted on follow-up, but obviously I am also an epidemiologist, and thank you, Professor McMullen, for making it known what that is. So I started checking what that actually meant. I came across a really interesting paper that was research that was done in Denmark. They took, I think, a sample of 20,000 people from the public, maybe 15,000, checked all of them for JAK2, followed up. All of those that came positive developed MPN and died within 15 years. not nice thing to read when you're in your 30s. Again, I went back to hematology, went back to being seen every 6 months, but nothing has changed. Everything was borderline. Until in 2018, I had severe abdominal pain. I went to A&E, pointless to go to A&E in the regional hospital here, unfortunately. But when the pain didn't subside and I wasn't satisfied with the explanations that were given, I went to the Galway clinic. They scanned me and they found that I had a clot in the spleen. Now, a clot in the spleen is something that's quite unique. It's not, that raises a lot of questions, and it's also very, very painful. They kept me there, very good treatment, and until hematologists will get a sense of what's the story. I saw a hematologist who explained that this is likely to be PV. We only need to do one more test, which is, bone marrow obviously, but to do JAK2 checking for JAK2 mutation. When I said that actually we do have that, I said, well then, this is what it is. And that was where the diagnosis came. I do wonder how many years before that, what is the actual onset of disease? It doesn't really matter. Since then, I was put as high-risk patient, given that I have thrombosis and that I have all the other risk factors. And I was put on Hydrea and aspirin, which I'm on since. Other than that, I am tired quite a bit. It could be because of a certain age that was mentioned here, which we blame on everything because, we don't really know, or because I work really hard, or because I always do loads of sports and don't sleep enough. It's hard to know. I think that most people in this day and age are tired. There's a lot of things that are taking our attention. And it really is difficult to know what is causing fatigue and what level of fatigue is okay and what is not okay. But it is good to know that there's reason for that. I'm very privileged to be working full-time in a work that allows me the flexibility to see my consultants, to go to hospitals without needing to look for parking, simply because I work in the university here, or need to take days off, or have any impact on my working life. I travel a lot, and that's not a problem. My disease is well managed, and I would consider myself, I consider myself a healthy individual. Yes, with some diagnosis on the side. But other than that, in terms of my life, I live my life to the full. I work, I exercise, I have social life. So for me, it wasn't, it's just something that I knew was going to come. I didn't know what cancer, but it was just a matter of when I will move from watchful wait to actual diagnosis. So for me, it wasn't the end of anything, really. Luckily, I dropped competitive sport before my diagnosis, which meant that I didn't even need to consider making a big change in my life. And for me, I'm not concerned about the future. I think that you get to a certain age where you have a chronic disease. This is just another chronic illness, very manageable for me. I appreciate that this isn't the case for everyone. I do have very good care here in Galway, and I appreciate that. And I think there's a lot of reasons to be optimistic. I think that time is on our side. The longer we live, the longer we have the hope that the cure will come. There isn't a cure now, but who knows? So time is on our side, and this is a disease that could be managed really well. So for me, it was quite, I still have questions. I do wonder if JAK2 is always acquired, and at what age could it be acquired. I do have questions about it. But that's only normal. It doesn't bother me. I don't ask myself, why me? It's just one of those things, because really, cancer is a matter of bad luck more than anything else. And of all cancers, this isn't the worst to get. So for me, it has been a quite easy journey. Again, life is managed really well. And if you're newly diagnosed, I think that you're very likely to be able to live a good life with minimum level of symptoms. So not too bad, really.
It's an amazingly positive story. Thank you so much. We're going to have a tea break, but after that we're coming into the breakout groups. And I need to just do a quick head count as to who's going into what group. We have in this room a joint ET-PV group, and I think there's quite a large number. So if you're ET-PV, could you put up your hands? Maz, could you? ET-PV. Now, if you're a family member, before we do a final...